previously unreached population were reached with services. And we had most of them actually being tested for HIV for the first time, and they were enrolled for antiretroviral treatment. So the results we achieved in a nutshell includes that comprehensive services are now available for the unreached population, and the FSW and the people aged between 25 to 29 made up the bulk of the population, and the interventions resulted in an improved access to care for this previously unreached population. So in conclusion, the EPIC project is going to consolidate on these lessons to actually do more, working closely with the government of Bayelsa State. And we are jointly saying that there is need for addressing some of the structural issues that prevent these people from accessing services. And some of them include things like unfavorable legislation that we talked about in the first slide. And to achieve sustainability, we will not be here forever. The government needs to invest more in this kind of innovative strategies so that more people can be reached outside the government facilities, and eventually they'll be transitioned to the facilities. Thank you very much for your time.
Thank you very much, Mr. Chidubem Orelisi. Thank you for the innovations that you're bringing. We're going to have our third presentation, and the title of the study is Knowledge and Attitude of Women of Childbearing Age Towards Exclusive Breastfeeding. And it will be taken by the author, Mary Donald Arce. Mary Donald Arce. Thank you, Madam.
Good morning, everyone. I am Mary Donald Arce, the State Nutrition Officer. I'm here to present a study on the knowledge and attitude of women of childbearing age towards exclusive breastfeeding in Yenagoa local government. Okay, the background. Well, breastfeeding is defined as an unequal way of providing an ideal food for the healthy growth and development of babies. From the definition, we are able to identify 4 points. An unequal. Breastfeeding cannot be equal with any type of food in the life of an infant. An ideal food for these infants and for the healthy growth and development of their life. And we have benefits of breastfeeding to the child, to the mother, to the family, and even to the society. We have, please, the next slide. Some of the benefits of breastfeeding to the infant is that it is the optimal food for the infant. It contains perfect nutrients. It is easily digestible and accepted efficient the baby. It protects against infection. And in fact, we refer to it as the first immunization to these babies because the first breast milk, the colostrum, is rich in antibodies to help protect these children against infection. It is rich in vitamin A for the healthy eyes of these children. And of course, babies that are breastfed, they cry less because as far as the breast is always available, they will not cry so much. Next slide, please. Now, benefits to the mother. In as much as the mothers will ask, what is my benefits for breastfeeding babies? Well, it helps for easy return of the uterus back to its pre-gravid state. Because as the baby is breastfeeding, message is sent to the brain to release oxytocin that helps contract the uterus, so that if there are any retained product of conception, it is expelled during that period. It helps to reduce breast cancer as much as 25% and also reduce uterine and ovarian cancer. And also, it is one of the benefits is that it helps a lot for also for child spacing to some mothers, though it is not for all, but it is a benefit. Please, the next slide. And we have other benefits. It is safe, it is hygienic, no preparation needed, psychological benefits. It creates bonding between mother and child. The next slide, please. Now for the study. The study was conducted in our Kudama Health Center. Women of childbearing age of from 18 years to 49 years that have children from birth to 2 years. And a descriptive study and a confidence sampling method was used to select 150 respondents. And the data collected was also analyzed with a questionnaire. Please, the next slide. And it was noted that about 105 out of these 150 women we are between the ages of 26. Then about 80 women had children they have 2 children and above. Then 142 had knowledge about exclusive breastfeeding. And even with this 142 out of the 150, they still have their reasons for not breastfeeding, which we will see later. Then about 10 mothers agreed that breastfeeding rate should be reduced. That was their own reason, that the 6 months of exclusive breastfeeding and 24 months is too long for them. Please, the next slide. Now, these are my report. The pattern of feeding of previous babies. Some part of the slide went off. Then some of them, like 74 out of the 150, combine breast milk with artificial feeding. But it is recommended that breastfeeding should start within 30 minutes to 60 minutes of delivery, where breastfeeding is initiated right in the labor room. After that, breastfeeding should continue for 6 months, and then it's also recommended that breastfeeding should continue for 24 months, as recommended by World Health Organization, UNICEF, and WABA, World Alliance of Breastfeeding Action. Now, information on exclusive breastfeeding, actually there's enough information, 26% headed from mass media. Then friends and family, about 32 out of them. Others who said they didn't know how it came about. Then 70 out of them headed from health centers. But even with that, they still have their reasons. Please, the next slide. Now, I have a distribution table. 1 to 2 months, those that have 1 to 2 months, we have 71 of them. 3 to 5 months, 35. 5 to 6 months, we have 34 of them. 6 months and above, we have 10. Then this also another variable that says below 20 years of age, we have 15 of them. Then that is the age of the mother and so on. Please, the next slide. Now, the conclusion. Breastfeeding. Program on breastfeeding should be extended to the other communities in the 8 LGA. This one is just, I'm just restricted because of funding to make this one just in one health facility to know what is going on. And I'm restricted by the slides, if not the charts that try to ask what are their reasons. And you know, the reasons are very funny. Most of them will say that their tradition do not permit breastfeeding, and what is the reason is that some of them will say when they start sleeping with their husband after delivery, they should stop breastfeeding. Why? Because they feel that the baby will start sucking the sperm from it, and which is not ideal. Some will tell you that they have small breasts and they will not be able to breastfeed. Of course, we cancel them. We take their number and sometimes we follow them up. And that even made me to go to plead with Radio Bayelsa to start having awareness creation to the public, where I was permitted for phone-in programs to try to address some of this. So that is then the conclusion. The conclusion is the program should be extended. It's because of resources I was not able to go far. Then recommendation, the government should have policies to encourage mothers to exclusively breastfeed, even when they have returned to work, because returning to work is one of the reasons. Then public seminars should be conducted to educate both the fathers and mothers to support exclusive breastfeeding, because we have discovered that most of the problem of not breastfeeding comes from the father. When the father will instruct the woman to stop breastfeeding, so that the contour of their breast will not lose shape and all that. So but we try to advise them and encourage them that, Lord, just permit our children to have just the liquid content only, and after that, you can do whatever you want to do with the breast. Thank you.
Thank you very Thank you very much, Mrs. Donald. I'll say thank you for the great work you're doing on exclusive breastfeeding. I'm sure the next time you're presenting this topic, you're going to tell us how many of our women actually practice exclusive breastfeeding. Like perhaps it might be, so that we know how well we need to do, whether we need to take the education to the community, or we need to go to the governor to increase the maternity leave for the women. Thank you very much, ma'am.
Yes, actually, she's talking about implementation science. Lessons from this will help the state government to adjust policies towards supporting women to do exclusive breastfeeding. Thank you so much. We are taking the last presentation for this session from Abisola Oladapo. She's talking to us on telemedicine for mothers at the bottom of the pyramid. Is she around? Yes, thank you very much. So let's hear her. 7 minutes.
Hello, good morning, everyone. Thank you so much for your time. My name is Bisola. Unfortunately, my slides were corrupted as we're sending it, so I'm going to have to speak from memory. So a little bit about me and why I'm here today. I'm Bisola, I'm the founder and CEO of a company called MomSpring, and we build technologies to help women at the bottom of the pyramid. So these are women who are making less than 50,000 Naira a month to get access to healthcare. Recently, we launched a program across 57 LCDs in Lagos, where we supported a few thousand women by providing them with antenatal information in Pidgin and Yoruba. And what we found in that cohort of women is that every single one of them were more likely to attend their antenatal clinics, and we're also more likely to pursue using a skilled birth attendant for delivery. Looking at some of the presentations we've seen here this week, I realized that Bayelsa also has the goal of reaching 100% coverage for ensuring that women's births are attended by skilled birth attendants. As of 2019, Bayelsa was at 36.6%. Looking at the success we've had in Lagos, with the cohort that we've supported in ensuring that almost 100%, about 98% of them use skilled birth attendants, we would like to deploy a similar pilot in Bayelsa State to ensure that women are able to get antenatal education during their pregnancy in their local languages, so Pidgin and any other local languages that are preferred by Bayelsa, and also provide them with 24/7 access to a midwife if they need it. So this means without airtime on their phone, without having access to data, they can reach a medical professional from the comfort of their home. One challenge that these women face is the cost of transportation to be able to get to the antenatal clinics. Many times they have so many responsibilities at home that they need to take care of, but being able to reach a medical professional, even if it's 2 a.m. or 2 p.m., has been so key in ensuring the utilization of the antenatal services provided by the state. And with that, our recommendation is that we partner with Bayelsa to deploy a similar project here in the States across your 8 local government areas and see how we can improve utilization of your primary healthcare services and also attendance of births by skilled birth attendants. Thank you very much.
Thank you very much, Abisola. I think We have come to the end of this session of oral presentations. I would like the co-chair to address the questions that will come from the floor.
So thank you very much. We'll just take 1 or 2 questions, maximum 2 questions across. So you'll be given the microphone to ask your question, just 2 questions maximum. So 1 and then another person, that's all, because we'll need to move out for the poster presentation.
Okay, a very quick one, madam. The breastfeeding presentation, I think you can sit down. Is there any particular reason why you decided to use convenient sampling, and yet you were extrapolating to the 8 local government areas of Bayelsa State? So I do recommend you take a second look at this paper. This is an academic community in a way. So 1 or 2 things. Either you limit your generalizations to the community you studied. If you wanted to extrapolate to the 8 LGAs, you needed some form of randomization, simple randomization. So that's just very basic statistically. But well done for the presentation. Thank you.
Thank you very much, sir. I think she's not doing a generalization now. Maybe it was a slip. So can we have a second question?
Good morning. Thank you very much for those great presentations. My question is for the last presenter. I just wanted to find out, it's quite an interesting and innovative. Sorry, my name. Okay, sorry, my name is Estelle Mbadiwe. I'm a founding partner of Disability Solutions. So my question is for the last speaker. I just wanted to find out, because it's quite an interesting method to reach out to the women, especially in states where you have a poor antenatal attendance. So I wanted to understand a bit better of the technology and the response feedback mechanism that you use for. Yes, because you said there is no data, they don't have to have data. So it's quite an interesting process.
Thank you for your question. So the way it works is we use automated phone calls or robocalls to reach out. All we need is their phone number, and we send them automated phone calls in their preferred language. And then we also create a toll-free helpline specific to that community or state, so that they can, without airtime on their phone, they can call the lines at any time of day. And the call center is staffed with midwives. And so today we use a blend of our staffed midwives and the state's midwives, but depending on availability of the midwives in the states, to ensure that they can reach someone at any time. And what we found is that we start to get a lot of questions around where they can have delivery, what services are possible, a lot of questions they have around even their blood types versus the child. And so there's a lot more engagement with the women and a lot more interest in using the health services provided by the states. Thank you.
Yeah. Thank you very much, Abisola. I think with that, we have come finally to the end of the oral presentations. At this point, please, we want to invite all the poster presenters to go upstairs and stand by their posters, while the Honorable Commissioner for Health will lead us to the poster presentation upstairs to enable us go through the posters, because not everybody was able to present here. Please, let's move upstairs for the poster presentation. Sorry, poster exhibition. Let's move upstairs for poster exhibition to be led by Honorable Commissioner of Health.
Thank you very much, Mr. Chair. As the Honorable Commissioner leads for the poster exhibition.
Hello. Can you wait for 1 second? I have one bad advice to advise you. Excuse me, it's an old man advice. You see this face mask? The face mask has 2 faces, the inner and the outer. Do you know what product is outside here in the blue? Is a formaldehyde. Please, when you are wearing your face mask, the white has to be in. for your own health. Otherwise, there are other complications which will follow later if you overuse it, because you will be breathing the formaldehyde. It's bad for your chest. Cancer and others will follow. Thank you.
Thank
My
you
bad
very
advice.
much, sir. Thank you.
Thank you very much for the bad advice.
So, Honorable Commissioner, please, once you're done with the poster exhibition, you have to also lead them outside for the exhibition outside before we come back in for the next session. Thank you very much, Chair, sir. Can the presenters please come and have good photograph? Presenters, please come and have group photograph with the chair, the commissioner, the chairman house committee on health. Please, presenters of the oral presentation, please come fast for group photograph. Please, again, the presenters, please. All those who made oral presentation, please, for group photographs, please. Can someone call outside? Someone please call any of them outside for the group photographs. Thank you. Thank you very much. All right, Commissioner, please lead them on the poster exhibition and then the exhibition outside. And immediately we'll come back in for the next session.
Thank you very much, Honorable Commissioner for Health and fellow delegates. The morning session for oral presentations and poster sessions have now come to a close. Please let us gather for the next session. Thank you very much.
Distinguished ladies and gentlemen, the Honorable Commissioner for Health and the Chairman House Committee on Health will be taking everyone now on a tour of the exhibition stand outside. Please, can you join the Honorable Commissioner and the Chairman House Committee on Health for the tour of the exhibition stands outside, please. All right, we'd like everyone to please take their seats as we move to the next plenary. And if you remember yesterday, we moved this particular session to today. That was a session on strategies, prospects, and challenges of implementing performance management and quality improvement in health. And so we'll have that now. After this particular session, we'll go on a tea break. And then when we come back, we'll have plenary 7. So please, we'd like everyone to take their seats now so we can formally start. All right, if we're ready, may I invite the chair for this session, Professor Dimie Ogoina. He's the Chief Medical Director of the Niger Delta University Teaching Hospital. Please put your hands together for him. You can do better. He's also the chairman of the local organizing committee. Please put your hands together for our chair. Thank you very much, Professor.
Thank you very much, MC. Good morning to everybody, the Honorable Commissioner for Health, the Chairman, House Committee for Health, specially invited guest participants. It's my pleasure to welcome us to this plenary, which happens to be the last invited plenary for the day before we go to aspects of our summit outcomes. So this plenary will be speaking to performance improvement and quality improvement, performance management and quality improvement in the health system. So I would like to, before I continue, introduce the co-chairs, the people that will assist me in the moderation of this plenary. It's my pleasure to invite to the table Dr. Obiama Obikeze, who is a consultant public health physician. He gave us a lecture yesterday, so we don't have to repeat his citation. You're welcome, sir. I would also like to introduce my second co-chair in the person of Dr. Ebika Okonye, who is health management and quality improvement expert, and also has vast experience in healthcare administration and certification in the same field. Dr. Ebika Okonye is over there. He will help to coordinate the collation and collection of questions from the physical audience and from the virtual audience. I'd like to inform us that this session will include the presentation that will be about 20 to 30 minutes, after which we have another 10 to 20 minutes, depends on the time, how the timing works out for questions and comments. We're going to permit people to make their comments, and if you want to write it down, we will do that. I'd also like to inform us that we have repertoires that will be documenting their recommendations and contributions from this plenary. So, as I said earlier on, the plenary speaks to performance management and quality improvement in the health system. And we know that we cannot change various aspects of our health system without implementing performance management and also looking at aspects of quality improvement. Today, we have a resource person in that field that is going to do justice to that topic. Permit me at this juncture to invite my co-chair to read the citation, the brief citation of the invited speaker, and invite him to give his lecture. Thank you.
Thank you, Mr. Chairman, Honorable Commissioner for Health, Chairman, House Committee on Health, other distinguished guests here present. I wish to, at this point, call out our guest speaker, Dr. Joseph Aliu. Dr. Joseph Aliu. Dr. Joseph Aliu is a trained, qualified, and experienced independent surveyor, otherwise addressed as hospital auditor, both with COSASA, Council for Health Service Accreditation of South Africa, with special recognition award for good audit leadership, and SQHN, Society for Quality in Health in Nigeria. An advanced cardiac life support trainer, a retired clinical health manager of Shell Hospital, Port Harcourt, and a practicing gynecologist obstetrician since 1991. As a hospital auditor, he has audited various hospitals for standards reached or accreditation purposes. Some of them include Shell Clinics, Reddington Hospital, Chevron Hospitals, NDUTH, and several cottage hospitals in Bayelsa. He is also a fellow of the West African College of Surgeons. Dear colleagues and invited guests, I present to you Dr. Joseph Aliu.
His Excellency, the Executive Governor, I'm happy, sir, the Honorable Commissioner is here. And with this, I stand on existing protocol. First of all, just to say, I'm so grateful to God that I am here on your kind invitation, sir. Thank you so much. Please extend my deep gratitude to His Excellency, the Visionary, and you personally, the convener. I particularly address you because I am trusting God that this is not going to be another talk show. We've attended so many. Being the first for Bayelsa State, I want to believe that implementations will take place. Thank you very much, sir. And my colleague, sir, Professor Goina, thank you so much. I've come to know him. Haven't had the privilege of visiting NDUTH on audit purposes. Distinguished colleagues, ladies and gentlemen, my topic, sorry, maybe I need to come up. Thank you, sir. First slide, please. I've tried to compress the slides a little bit because of the time now allotted to me. Please, Prof, when it's 15 minutes, be kind enough to give me a signal. Thank you, because I have two major topics there. Strategies, prospects, and challenges of implementing performance management and quality improvement in health. So the two keywords are performance management and then, no, backslide, please. Performance management and quality. When we're talking about quality, we're talking now about the whole of whatever we have to give in healthcare. And performance management is a key subsection. So we're first going to concentrate on performance management and thereafter dovetail into quality improvement. Next slide, performance management. We move on to definitions because that is the basic thing about what we are talking about. And we have about 5 different definitions to show you that if we grasp the definition very well, we are through, home and dry. And the first one talks about a systemic process which a manager can use to get the team members to achieve the team's objectives and targets improve overall team effectiveness, develop performance capabilities, review and assess team and individual performance with reward and motivation. So we're talking to managers, and please, I want us to know that by and large, we may think that, yes, we are employees. Yes, we are in a team. That is fair enough. But we are also managers. You may be a top-level manager. You may be a middle-level manager. You may be a low-level manager. But you are a manager. So as I address my dear friend, Prof., as I address the Honorable Commissioner, I also address each and every one of us so that we know that we all have roles to play. And nothing can be beautiful other than the fact that, look, even if there are no new investments, what we have, particularly the human resource, can we develop it? Can we improve the quality of our output, of the instruments that we use, of the environment that we have? Next slide, please. 4 other definitions. And this is by a man, Michael Armstrong, who says, performance management is the continuous process of improving performance by setting individual and team goals, which are aligned to the strategic goals of the organization. Planning performance to achieve the goals, reviewing and assessing progress, and developing the knowledge, skills, and capabilities of the people. The important thing is the organization. We're not talking of individual agenda. We're not talking of self-promotion. But what do you do within that whole to bring about a move upwards, forwards, so that when people look back at Bayelsa, and I will be glad to hear that Bayelsa has become a model in performance management. Next slide. A strategic, this is by Armstrong and Barron, strategic and integrated approach to increasing the effectiveness of organizations by improving the performance of the people who work in them and by developing the capabilities of teams and individual contributors. 2 more. Go on, next slide. That's by Lockett. I think we can move to the next slide. Let's conclude the definition. Moran and Moran talks about performance management as managing the business. Cute. If you remember that alone, I hope that you will now extrapolate to know the various things attendant thereof. Walter says performance management is the process of directing and supporting employees to work as effectively and efficiently as possible in line with the needs of the organization. Now, let's see what are the next slide, please. Now, effective management requires identifying the tasks. So if you are talking about the organization, what is the goal? What is the task ahead? What is the objective? Identify it. You may derive it from the vision of whatever organization you have. And when I talk, basically, the talk is directed at the hospital, but we're talking by and large, the totality of healthcare. So secondly, defining competencies necessary to be successful in a position. Maybe I better be fast. Ensuring if there is anything I have not explained well because of time, I have to compress a lot of the talk. Please note it down. You can ask me as questions. Defining competencies necessary to be successful in a position. So both the manager and the managed, you have to define what are the competencies. Ask yourself, you are a manager, what are even the competencies for me to succeed as a manager? You are being managed. What are the competencies? You may have been in clinical duties. It doesn't matter. What are the developments? Do I have enough competency to advance this place forward? And having in place a system to develop competency. Maybe I better just stop here so that I don't forget. I didn't particularly mention it. Sir, Honorable Commissioner, the state may consider having a training school. For example, when I talk very soon about improvement, we're talking now about competencies. We may decide to import a teacher that will teach maybe about 50 people on infection control, for example, infection control. They don't necessarily have to go out. That is, I'm just using it as an example in case we do not have such a competency here. So we may decide to have a training school, a training area, if they are not already with the various institutions, providing timely feedback on how effectively the team members are applying. We're going to expatiate on this in a moment. Next slide, please. Next slide. So what is performance management system? We've defined performance management, but you see, it's essentially the same thing. But the shift is performance management into a performance management system in line with what we used to have. Paperwork now shifting to the electronic management system, whereby you are able to store more data and you are able to retrieve more data. You can play around more with the data. That is what performance management system seeks to deal with. Next slide. So the tools that are needed are there in whatever you have as your software to manage the system. And it enables continuous performance management. Continuous is the word, not what many of us have been used to, even for those who have it, annual appraisal. I don't know how many institutions have it. I don't know how many of us are used to annual appraisal. What do you use it for? But now we are talking about continuous management, which I will mention in a moment. 2, it offers 360 degrees performance assessment. What is 360 degrees? You are not only assessed by your boss, you are assessed by other stakeholders. They may be suppliers, your peers. How did they see you? Are you just a boy to the manager, yet you don't do anything in the department? We have 360 degrees. In fact, these days, people have shifted it further to 720 degrees management assessment for you. Then improve the frequency of feedback. Next slide. It ensures a fair performance appraisal process. A fair performance. It's not that I like you. I like you because you are contributing a lot to the business. You are contributing a lot to furthering the progress, the quality that we produce in this, whatever your institution. I like you for that. And it will be evident to all. So it will be across business. Make it easy to track employee performance, identifying training requirements, automating performance review reporting, and very importantly, onboarding. In case you are not familiar with the term onboarding, onboarding is when a new person is employed. Is he introduced to the system? In my time, when you are employed, the day you come, you just go to your desk. You don't even know who your neighbors are. You don't know the department you are supposed to interact with. You don't know the rules. You don't know the culture of the environment. Well, you just know that you have been employed as a senior house officer, and that is it. Onboarding seeks to protect that. What is your immunization status? Are you okay to work with us and with other people? Or are you even a risk with them? Onboarding deals with that. And that is quality. We're talking about performance management. Go ahead, go ahead. Slide, next slide, please. Next slide. Oh, sorry, it's with me. Okay, thank you. Deloitte, when there was a shift from what was an annual appraisal process to the new system, unfortunately, most of the data that we tend to have are from private institutions. And I am still trusting God that with the able direction of the Commissioner of Health, Honorable Commissioner, sir, that it will go into public institutions so that we can have a process where if I'm working there, I work to the best of my ability because I want the health of my people through that institution to be improved. But what we have, they are private data because most of these things were talked about in private setup. For private setup is part of what we're talking about, the totality of health delivery. But Deloitte said that modern performance management, it has progressed to the extent that highly motivated employees are proved to be 125% more productive when you use a performance management system in its current management form. Next slide. Next slide. Yeah. Stress. We have our own version of stress. It may not be like European countries, but we have our own version of stress for the individual employee. But it's been found that when people are supported in stress-related condition, they have a lower turnover, for example, of absenteeism. Go ahead. A good performance management tool includes a section. The tool must include the 360-degree feedback that we talk about. Then you talk about ratings and scores. 15 minutes gone. Please move. Let me see if I can move the slide further. Three minutes. Thank you, sir. I'm happy, sir. The Honorable Commissioner overruled them. Thank you, sir. I know it's from, of course. Thank you, sir. Let me be fast. Sorry, this thing is not, okay, it's moving now. It's going back, sorry. All right. Well, when you have the system as well, it spots underperformance and triggers performance improvement from the one-on-one discussion. We're going to discuss how do you go about it. This is what we have. Honestly, when you do this continuous improvement plan, as we are discussing it, it increases motivation for staff and it increases their morale. You have better employee retention and you save a lot of time. In its older form, this was what you have. You can pick anyone. They are all there. Is it a feedback? Whatever it is, corrective measures. But it wasn't in a well-organized system as we have now, which is that organizations' goals and values are there. If you notice, in this particular plan that you can see, there is no arrow because it is plan, act, track, review, and you do it as frequently as possible. There are some organizations who even do it maybe monthly, others do it quarterly. Now, these are the things. At the start, agree on goals. What are the objectives? It should be smart. It should be smart, time measured. A personal development plan. What has the person identified as deficiencies towards achieving the goals? Actions to be taken, they are discussed. And then a review of the employee's job requirement, updating the role profile where necessary. Now, this is the new one. You now see, it's just 2 items there. You check in with your manager, whoever your manager is. For example, if it's the laboratory, who is the head of laboratory? The chief medical director or the medical director manages the heads of departments. The head of department manages his team or sub areas, and you discuss all this generally. So you check in with your manager, work on objectives, and you get feedback on the spot. You check in with your manager, work on objectives, you get your whatever it is, 1 to 3 more. What do you do in checking in? Progress against existing objectives, personal development, priorities, issues, concern, whatever. So let's move on. These are the benefits to the organization. Now, what makes performance management uninspiring? The system isn't fair. It's not seen to be fair. Or it's not accurate. You will get people who will cry unto you on the spot because he knows that my performance is going down. In fact, in performance officially, when you do it very well, we talk of ranking in that organization. Who is the number one in the organization? Who is the last in the organization? You will get people who will whip on you, but that's why you are the manager. You will take it. You will encourage the person. Go on. And in the experience that I have had as a manager in Shell, you get people who cry like this, but the following year, because of performance management, you see them almost being on top. And they are now much more dedicated. So managers treating employees as if, oh, just stick it. Okay, it's time for performance management. Okay, come in. You just stick it. No, it's a very serious business. And then secondly, the system is focused more on appraisal than on coaching. There are various forms of coaching. You can handhold whatever the coaching method to make sure the person sees that we are interested in your progress. It's only the uncoachable that we eventually have to leave the system. Wrong design, absence of integration, lack of leadership commitment, which I have talked about. So, sorry, I think we just jumped through these slides because we have many more. This is what you use. Performance appraiser. How often do you communicate? It's not prescribed. I think we've answered that. Who initiates more often than not? Your manager initiates. What are the topics for discussion or communication? Goal alignment, goal adjustment, great goal progress, and feedback. How much documentation? You document after every conversation. And then, now, suggestions. Please, whatever needs to be changed to get to this issue, because I know it may not be very much native to our system as government officials. There are already prescribed modes of whether discipline or promotion or whatever it is. But we need adjustment for the healthcare. We need adjustment. Because if your manager says, sorry, you have done this, you are not doing well in this, he says, sorry, the civil service guideline says I must stay here. Then there's nothing the manager can do. In that case, that process he wants to initiate will soon come to zero because everybody will laugh at him or her. So prepare staff for performance management. Haven't gotten approval therefore, or whatever needs to be changed, or whatever can fit into the current existing problem, then please prepare your staff if you are not already doing appraisal or performance improvement management. If you're not already, get them ready. Let them have a buy-in. Let them know what you're doing. Then expect great resistance, but please remain calm. Have a trial run. Start on full performance management the following year. Okay. Now, we quickly move on to strategies and prospects for quality improvement. We have talked of SQHN, Society for Quality in Healthcare in Nigeria. That is the logo. We also have Safe Care. And I think Mrs. I've not seen her here. Mrs. Sindeli was here yesterday on Farm Access. Okay, that is their outfit. And this one helps us with lower resource setting, especially rural, maybe primary health center, rather than going for the bigger stuff of possibly SQHN. And much more importantly, the one I'm going to talk about, which I will mention very soon. This is the normal pyramid. You have assessor organization. So SQHN is an assessor organization, and they assess various institutions on invitation. Now, as assessor organization, they are not static. They are improving on their document. So once every 4 years, they submit their document to ISQA. They submit to ISQA, which is the International Society for Quality in around the world, and they approve the document, and that's the document they use for the next 4 years. And when that happens, okay, please, can I have the slide on COSASA? COSASA just means Council for Health, exactly. This is COSASA, accreditation standard. Health Council for Health Service Accreditation. Forget that is of Southern Africa. I got introduced to them. And that was where I trained. Please scroll up, keep scrolling. It's okay, it's okay. No, scroll down, just that first page. You now see that it has everybody into it. If you are talking of accrediting your organization on quality, it's only when you meet their quality objective that you'll be accredited. First of all, even management and leadership, are they doing their role in terms of policy? Have they brought the policy? Have they explained the policy? You talk about human resource. The human resource, the performance management we're talking about comes under human resource. And every evidence must be shown that you are on performance improvement. There's every evidence. What's your annual appraisal? What have they done about it? Administrative support. It talks about finance, so many other things. So certain level of compliance is expected. So when you go through all of this, right through, depending on your hospital, what you have, then we will talk of, this is a hospital of standard. I mentioned infection control, waste disposal. What even is the infrastructure? Somebody asked a question yesterday on pharmacy, maybe not enough stores. Those will be part of what is assessed for quality, because the drugs must be stored properly and well with enough space. So please, overall, across board, I wish that the Honorable Commissioner has the power and decrees that every hospital or health institution should ascribe whether SQHN and try and get quality. The good thing about this is that when you hear of audit, when I was a consultant in the teaching hospital before I joined Shell, when you hear of audit, you get terrified. What are they looking for? These people have come. They really want to deal with us. They are looking for force. And truly that was how it was. You didn't know what the standards were. This one, the document will be given to you. You go and work it out. See your deficiencies as per the document. And then you are encouraged, correct them. When you have corrected them and you are satisfied, invite us to come and check with you. And then your standard improves. Why will, before Corona came, some of us didn't know how to wash hands, even though we are in a healthcare industry. We didn't know how to wash hands. That is infection control. Some of us were not bothered about waste disposal. What about waste segregation? You get some hospital, office paper is mixed with gloves that are bloody. You see people washing cloth that is soiled with hand. Standards. So I have how many minutes more? 5. I shall round up. Thank you. All right. I think I've basically passed on what I want to. Please move on. Next line on KPI. Key performance indicators, quickly. Okay. Now, when you talk about I have the definitions. Key performance indicators. What is your own target? When you talk about key performance indicator, what is the performance indicator of your own unit that if you achieve it, you say, yes, I have. Let's take, for example, one doctor mentioned yesterday, let's say, is it time? Movement time, for example. Somebody comes to the hospital, OPD, and ends up finding, don't go to the hospital. You just go, just to see the doctor, you spend 8 hours. Have you tried to improve your timing? Have you tried, apart from timing, where are the bottlenecks? Have you identified them? It's not impossible. The doctor is not there. The nurse is not there. The technologist is not there. So the sample is waiting. What is it? What about the turnaround time? Can any hospital tell you that we have our turnaround time, blood taking, emergency full blood count? You will get the result in 30 minutes. And then you start to measure your time with all the emergency blood sample. Did you get them within 30 minutes? When did the doctor review? After an emergency patient came. The timing is there because even the case notes are audited for standards. All of them. So when you talk about key performance indicators, every unit should have a key performance indicator. Everything focused on what is the final goal. And next slide, quickly, please. My time is up. No, forget about KPIs. There are many KPIs. Every unit has a KPI. whether you are outside the hospital or not, there are KPIs for you. Next, the main slides, the main PowerPoint slides. Okay, it's not coming up. Finally, when you go on therefore, I'm just appealing. I am part of the team. What is my improvement? What do I have to contribute to quality? I went upstairs and I was going through one of the posters, and one of them had a beautiful conclusion, which is the old-time listing of performance quality improvement that we've been talking about. Just a little bit of it, morbidity, mortality. And the conclusion is that publication will end up publicized. The person gets his promotion. But what of on ground where it was done? Was the loop closed out? Was it closed out? Did you follow to pursue the conclusion as simple as they are? That is performance improvement. Now, hopefully that when we have done all the basics and you are up there and people can refer to your hospital, when you are doing new standards, it will further improve or at least maintain that high standard. Ladies and gentlemen, go on. Let me now go to the last slide. The last slide is similar with an appeal that please, quality is very important. Even if, like I said at the beginning, even if you don't have new equipment, let's see, we can do quality. We can improve. We can improve both in our personal improvement plan and generally in the hospital area, whereby the environment will be proud of us. Your infection rate will fall. We talked about cesarean rate. So many things. Availability. Sir, I am done. Thank you very much.
Okay, thank you very much, Dr. Joseph Aliu. I'm not surprised that you've done justice. You always spoke with a lot of passion. So I'm not surprised you have done justice to that topic. I know you still have a lot in you to give out. So I'm sure when people make comments and contributions and ask questions, you'll be able to provide some answers. Using the privilege as the chair, I'd like to be the first to provide my contribution, if you don't mind. So I say I want to make a contribution because Dr. Aliu talked about COSASA. And as a hospital, and when you were reading his profile, he talked about the team from SPDC and COSASA came to our hospital to do accreditation because we, at that time, wanted to be the first public hospital in Nigeria with COSASA accreditation. And that accreditation was under the leadership of the former Chief Medical Director, Professor Mrs. Kunle Olowu. So they came to do the accreditation in about 2012, and you're required to score 80% to get accredited by COSASA. Once they did that accreditation, we scored 27%. And we learned a lot of lessons that I want to briefly just share. The first thing was that we observed that we did not have standards for so many things. There are no standards for so many things. And we required to set standards for so many things that we were doing. So hospital had to set up a lot of policies, amongst others. We also realized that we did not have performance indicators for most of our departments. So the hospital has to also set up performance indicators. And there was also no process to monitor, to audit. So there had to be clinical audits and clinical governance and the likes. And so we observed some improvement. Over time, the first time COSASA came from South Africa, sponsored by Shell. Then subsequently, Shell Nigeria also supported us in the visits. And we improved ultimately from 2012 to 2017, where we scored 57%. 57%. That was still far from the 80%. But there are some lessons that we learned. And some of the lessons included, one, attitude of public servants. And the perception that quality improvement and standards are meant for private sector, not public sector. The second challenge was the fact that there were welfare issues and issues of human resource. For instance, I remember there was a year we were not paid salary for 3 months. And my staff said they cannot do quality improvement if they are not paid salary. There are also issues of human resource where you don't have sufficient human resource. There's no way you can implement quality improvement. There's also the challenge of lack of capacity. A number of the staff did not have sufficient capacity to implement quality improvement. But I'd like to say that on account of our experience with quality improvement, there are a lot of things we are even doing as a hospital. For instance, we routinely monitor absenteeism. We routinely monitor mortality outcomes and incomes, and even from the CMAX office. A lot of all this process goes on in the hospital. It may not be perfect, but I think we have learned a lot of lessons from COSASA and performance improvement and quality improvement. And it is something that will be useful to the Bayelsa health system. We know that as part of the National Strategic Development Plan, it includes performance review for health systems. That's very important. And we have talked about challenges of human resources. One way to address that challenge is also performance management. I'd like to hand over to our co-chair to please take the questions and comments of others. Thank you.
Thank you very much, Mr. Chair and presenter. We had online participation and physical participation in this session. There was no question from the online participation, but the audience, we have a collection of questions. Let me take the first question, sir. The question is, how does performance management and appraisal influence staff motivation? That's the first question.
Can I quickly answer that, sir? Thank you. When there is appraisal, you know where you stand as per the set goals. Take, for example, you have agreed goals with your manager. And then by the time you have talked one-on-one, you are now convinced that, look, I'm far from my goal. Let's give it some figures. Let's say you've only scored 40%. Of course, you know you have to go and sit up. Take, for example, transit time. Transit time, maybe it's 15 minutes. And because often you are not present for no tangible reason, our transit time is getting to 25%. In the discussion, it will show you are pulling the department down. Of course, you don't expect to score high. If at the same time, okay, we can classify whatever you do in the overall scoring. You are poor. You are okay, just average. That is, you are meeting your target. You are above target. That is, you've done your work. You are even doing more for the department, maybe even covering for those who are silently absent, and then you can be outstanding. Of course, the person who is outstanding will receive motivation, whatever the motivation, whatever they can. Is it a cash gift? Is it a present? But those of you, if you are low down, you'll be told to sit up. If you continue like that in annual appraisal, overall appraisal for 3 years, then the next thing is to start looking for how you go away from that department. And so the performance improvement is you are told where you are. Please, what are the problems? Okay, these are the issues. We'll see how I as a manager, I can help you so that you can perform better.
Thank you very much, sir. Please, a round of applause for our presenter. May I take the second question, which is also closely related to the first? What are your key recommendations for healthcare workers in Bayelsa State for performance management?
Thank you. For performance management, please embrace the idea. It will help each and every one of us. I know the good thing about it, and I started by commending us for all that we bear. You know, but the good thing, most of us want where we work to be able to offer better service. Especially if you're from Bayelsa, and including those from outside, your environment, you want the people to smile better. it can be achieved through performance management, which will also help us change our attitude. Apply yourself to the job. That is what I would say about it. Accept performance management.
Thank you very much, sir, for that apt response. The last question from another participant is, what are your thoughts about work plans and target setting in appraisal for performance management?
When we talked about at the initial, let's say in January, which is the start of the year, you meet with your manager, you agree what are the objectives. He hopefully has an idea of the overall objective of that institution. Let me, with due respect, sir, Prof, let me use NDUTH as an example. Professor has the overall objective where what we want to achieve this year. And hopefully he has shared it out to his own managers who may be heads of department. The department takes it. We want better service. The objective of hematology will be different from clinical medicine. Maybe last year, they said infection rate was 30%. No. Our key objective, which the CMD shares with us, is that infection rate must reduce. Fine. So the clinicians take it, at least the surgeon. But also pathology, we also take it. What are we doing? Have we, especially microbiology, what is the antibiotic in use? They all review. So you set targets drawing from there. And then the people in the microbiology, the head of unit, will discuss with them. This is what I want. You are going to be in charge of antimicrobial therapy for this year. Let's see, work with all the clinicians. And then he will give you feedback. It's not impossible that at the end of the year, Prof will be very happy that it was 30-something. Now it's 9%. Your own manager will commend you. Antimicrobial therapy, you worked on it. There were no complaints from the doctor. There was no delay. We've changed our antibiotic therapy because we never knew there was resistance in the hospital. I'm just giving one example of how people can draw up. And obviously, the quality in that hospital will improve.
Thank you very much. Please, a round of applause for our presenter. Let me take the last question and I will hand over to the chair of this section. The question, I'm paraphrasing the question. What are your key recommendations for reward and motivation for health workers in Bayelsa State?
Very difficult question. It's not impossible that some of us want monetary reward, financial reward. It may be a plaque, an honored at the end of year party for the whole department. Some people may value that more. But I think, to be honest with you, it varies from hospital to hospital. The hospital will look at a hospital that has not been able to pay salaries for three months. If the chief executive is offering monetary reward, you ask him, where did you get the money from? Thank you, sir.
Thank you very much. Please, a round of applause as I hand over to our chair.
Thank you very much, everybody. I would like to permit one of our invited guests, who is the former chief medical director of University College Hospital. And he has a lot of experience on the implementation of quality improvement, being in charge of a big hospital. I also haven't worked with Shell for a while, so I'd just like to invite him to make comments in 2 minutes.
Thank you very much. I think, let me congratulate Dr. Ali. You are smiling because you're a fellow gynecologist. And Professor Goina, you must be very bold to really confront Kosaka that they should come. Many of your colleagues, they run away from such a thing. And I think in the course of this summit, I have tried to intimate you people about the new checklist. And I think I've handed a copy to the commissioner. Because right now, we have a body, a committee established by law. in Abuja, National Tertiary Health Institute Career Committee, of which I currently chair, to look at standards and quality. But I must tell you that without quality, we'll be wasting our time and you will never get maximum return on your investments. But one thing that we keep on looking at is the clinical aspect. In hospitals, what confronts you at times and you will almost be thrown off balance is the non-clinical aspect, the downtime of the equipment. Equipments are not working. Yet we don't have competent biomedical engineers and technicians. Luckily, a past president in this country is trying to establish an outfit for that, an institution of biomedical engineering. Again, maybe don't say I'm playing to the gallery. I'm the chair of that implementation, which is a 7-story building. You know, because when your engineers in the hospital and your technicians don't know what to do about generators, they don't know what to do about simple centrifuge, you are in trouble. And at times it might just be a fuse. And patients will come, nothing is, the X-ray machine is not working, it's just fuse or something. And the patient's waiting time will get prolonged. So I think I will implore all of you to carefully look into this aspect. Is whether you like it or not, it affects quality. Thank you.
Okay, we'd like to appreciate guest speaker, Dr. Joseph Aliu, for giving us an overview of performance management and quality improvement. I think it was a very exciting lecture that you've given, and it has generated a lot of discussions. Even people, I'm sure after this event, people are going to meet you to take the discussion further. Let me also appreciate all participants for listening and for the contribution. I also like to appreciate my co-chair, Dr. Bikeze and Dr. Okoye. Thank you very much. I think this session has come to a close. Thank you.
Thank you very much, Dr. Aliu. Thank you, Professor Ogoina. Please, would like him and Prof and co-chairs to take the group photographs. Please, the Chairman House Committee on Health, join them, please.
Ready to pair.
Pair where now? All right, thank you very much. We'll go on tea break for about 20 minutes, and then we'll be back here for the next session, please.
Connected. 0, 9, 0. Ready to pair. Connected.
there I go, there I go. Pretty baby, you are the soul who snaps my control. Such a funny thing, but every time I'm near you, I never can behave. You give me a smile and I'm wrapped up in your magic. Music all around me, crazy music, music that keeps calling me so very close to you. Turns me your slave. Come do with me anything that you want to. Anything, baby, just let me get next to you. Am I insane? Or do I really see heaven in your eyes? Bright as stars that shine up above you in the clear blue skies. How I worry about you, just can't live my life without you, baby. Come here, don't have no fear. Oh, is there wonder why I'm really feeling in the mood for love? So tell me why stop to think about this weather, my dear. This little dream might fade away. There I go down out of my head again. Maybe time I talk together. That would make me strong and brave. Oh, when we are one, I'm not afraid, I'm not afraid. If there's a cloud up above us, go on and let it rain. I'm sure our love together will do the hurricane. Oh, my baby, would you please let me love you and get a release from this awful mystery? What is all this talk about loving me, my sweet? I am not afraid, not anymore, not like before. Don't you understand me? Come on and please pull yourself together, do everything. My heart's on fire. Come on and take me off me. Would you make me my darling, my sweet? Oh, pretty baby, you make me feel so good. Let me take you by the hand. Come, let us visit out there in that new promised land. Maybe there we can find a good place to love and stay combined. I'm so crazy about love, never knowing what love's all about. James, will you come on in, man? You can blow now if you want to. There I go, there I go, there I go, there I go. Pretty baby, you are the soul who snaps my control. Such a funny thing, but every time I'm near you, I never can behave. You give me a smile and I'm wrapped up in your magic. Music all around me, crazy music, music that keeps calling me so very close to you. Turns me your slave. Come do with me anything that you want to. Anything, baby, just let me get next to you. Am I insane? Or do I really see heaven in your eyes? Bright as stars that shine up above you in the clear blue sky. How I worry about you, just can't live my life without you, baby. Come here, don't have no fear. Oh, is there wonder why I'm really feeling in the mood for love? So tell me why stop to think about this weather, my dear. This little dream might fade away. There I go down out of my head again. Oh, baby, won't come and put our hearts together. Oh, when we are one, I'm not afraid, I'm not afraid. If there's a cloud up above us, go on and let it rain. I'm sure our love together will do the hurricane. Oh, my baby, please let me love you and get a release from this moment.
Distinguished ladies and gentlemen, you're welcome back from the tea break. And so we will make please, can we have the presentation on development of a framework for state health system performance improvement plan on the screen, please? On the screen, let us have development of a framework for state health systems performance improvement plan under plenary session 7, please. All right. I would like to invite to the table again the chair for this session, Dr. Professor Dimie Ogoina. Please put your hands together for Prof. He's chairing this session. If you look at your program, we're on plenary session 7, but we're not taking the first one. We're taking the second one right now, development of a framework for state health systems performance improvement plan. That's the one we are taking right now. After that, we'll go back to the first one on plenary 7, please.
Thank you very much, MC. So this plenary is a very important plenary where we'll be discussing and seeking our opinions and inputs from participants and our guests on one of the expected outcomes of this Bayelsa Health Summit, which is the development of a 10-year health system improvement plan for the state. So what we presented today, because the development of a 10-year health system improvement plan is a post-summit activity. It involves a lot of detail. But we felt that we will use the opportunity of this health summit where we have participants from diverse groups, both public, private, international organizations, to agree on a framework for this improvement plan that we intend to achieve as part of one of the expected outcomes of this Bayelsa Health Summit. Before I proceed, I would like to introduce the co-chair of this session, in the person of Dr. Neni Aworabioki. She is the director in the Primary Health Care Board and also a public health physician. So let me, with pleasure, also introduce the speaker that will be representing the Summit Planning Committee in presenting this framework. And the person of Dr. Ebika Okoye. He is the program manager of Saving 1 Million Lives, a program for results. Dr. Ebika, over to you.
Okay, let me stand on the protocols that have been established already. Over the past few days, we have had a lot of engagement, a lot of discussions here. And then a lot of thoughts, a lot of ideas have been brought to the table. And today we had a very important and robust discussion about performance improvement and quality improvement. So on behalf of the Bayelsa State Summit Planning Committee, I'm here to present to us a framework for the proposed Bayelsa State Health Systems Performance Improvement Plan. I'm having a bit of challenge with my, slides. Okay, that's fine. We all know that health systems is a component of different building blocks. And then strengthening our healthcare system is one of the major outcomes of this health summit. And as a template to this summit, a situational analysis of the health sector was done, and a whole lot have come to the forefront. These presentations and discussions and other presentations that have been made here have all exposed a whole lot that we need as a people and as stakeholders to look at the opportunities that have been presented for us to make an improvement. So there is an attempt to develop a 10-year health system improvement plan. And the core activity for the development of the health systems improvement plan is actually a post-summit activity. So the input of all of us as stakeholders after today will all be brought to that single activity that is critical for the state to move forward for the health systems improvement plan of 10 years. This is just the first step. And this goal is to adopt this framework that is being proposed today and is open for contributions, for more ideas as regards to the framework that is being presented today. The objectives of this presentation is to summarize priority challenges of the Bayelsa State Health Care System. And this has been one of the elements that we have identified through the use of the situational analysis and also the observations and contributions from participants in this summit. The objective of this presentation is also to suggest this framework that we'll all see. And it's the framework that attempts to address our priority challenges. We'll get further inputs and recommendations. What's led to this framework is a situational analysis to identify our strengths, our weaknesses, our opportunities, and our threats in Bayelsa State. This we shared widely with our stakeholders, and copies will still made available to all stakeholders that are here for further input. The SWOT gave a vivid picture, and there's need for us to address those issues that are largely relevant for improvement in the Bayelsa State health system. Prioritization is a key process for improvement. The numerous challenges may not all be addressed in one-off time. You will have a whole lot, a plethora of challenges that were presented here and discussed. And so there was need to prioritize and to look at what is most feasible, what is most beneficial, what is cost effective, what is implementable for our state to have our quick wins and to make the required improvements. Prioritization process is largely a process that involves all stakeholders. And that is also one of the key reasons why we are all gathered here as stakeholders in the healthcare sector to prioritize what we need to address as a state for improvement. The World Health Organization prioritization document that outlines strategies for improving health systems in the 21st century was a guiding document, and key issues that lead in an attempt to prioritize what we need to address talks about our vision, our mission, and our objective as a state. And this is also in relation to the mission, the vision, and the objective of our national health policy. It also looks at the principles of the National Health Act, which as a state we are to adopt, and then we are on that pathway to have our own state health law. We also look at the National Strategic Health Development Plan and the State Health Development Plan. And also key to this process is the goals of universal health coverage. And also key to this process is looking at the component of responsiveness as a healthcare delivery system. This attempt to look at responsiveness of our system will look at the values of our population. What are the needs of our people, and what is their demand for healthcare? The burden of disease is also a priority item that led us and will also lead us further in deciding what we need to address and what we need to improve on. Other aspects that guide the process of prioritizing is an attempt to look at fairness of intervention. Does he address the issue of reaching out to all that is needed? Does it address the issue of inclusion? And an attempt is also looked at the cost of intervention. Is there of cost benefit? Is it what is easily implementable? Is it effective? And that intervention, is it acceptable? Major challenges that are identified in the SWOT that we have provided across our stakeholders is as presented here based on the pillars of the health system, governance and leadership. We have all here spoken about the need for the state health law, which we don't have now. We have also identified that there is no state health policy. There has never been a Council of Health meeting. And there's also the issue of accountability that is lacking in our healthcare system in Bayelsa. Also, we looked at the pillar of service delivery, which in one of our discussions, our permanent secretary portrayed a vivid picture of our geographical challenge that is a barrier to access to healthcare. The issue of lack of minimum state service package that is for the secondary and tertiary levels of healthcare is lacking. And one of the key things from the presentation we just had was the issue about performance management, which is also lacking in our pillar of service delivery. Issue of health care financing as a pillar, a whole lot of discussions came yesterday, and there was need for the state to strategize on expanding our physical space, because we already know that the out-of-pocket expenditure is very high for our population. Infrastructure lack was displayed here. So an attempt is necessary for addressing our infrastructure lack. And there's need for us to also identify that routine healthcare facility assessment is not being done. The issue of human resource has been discussed extensively. The issue of partnership from our SWOT revealed that we had limited partnership, and there is no state policy on public-private partnership. No plan in place. The issue of research for health identified that no state health research policy and priorities, and there was no state research strategy. On health information systems, a whole lot was identified as priority areas that we may need to look at. Limited ICT infrastructure. We have challenge with implementation of the electronic medical records. Community participation and stakeholder engagement is inadequate. The social determinants of health, poverty, and unemployment are key issues that are challenges to us as a people. Commodities are inadequate. The list is endless, but we need to have a framework to address these are challenges. And here we propose that framework that we need the input of all of us as stakeholders to decide, to make inputs, to improve on, and to develop as a working document to ensure that all that we have discussed here bring out that outcome of an optimal performing healthcare system in our state. We looked at the building blocks, the priorities, what is our baseline, what is our target, do we need any pre-intervention planning, do we need an improvement for that intervention, do we need a time frame? We must have absolutely a time frame to work with. Is it a short time, a mid-term, or long-term intervention that will bring about the outcomes we want? And of course, improvement will need sustainability. Who is responsible for that intervention? How do we get funding for that intervention? And then, if you don't monitor and if you don't evaluate, how do we know change has taken place? So I've listed here the building blocks which cut across what we have done in the situational analysis, leadership and governance, human resource, finance, commodities, service delivery, infrastructure, community engagement, partnership, research, and health security, which is a major issue that is on the table now, considering our present reality of COVID-19. How do we use this framework? Looking at our first building block, health infrastructure. Our priority challenge is no health infrastructure, and generally there is decay of our infrastructure. Our baseline is we don't have health infrastructure plan. We don't do service readiness scores. We don't do service availability assessment in the state. Health infrastructure plan is to be developed as our target. And then another target is to ensure that at least we have one primary healthcare center that is functional, well-equipped in each of the wards. We have at least one secondary healthcare center, a general hospital that is well-equipped and functional in each of the local government areas of the states. The pre-intervention planning stage, we require to do a health needs assessment to be able to determine the intervention that we need. The improvement that we need is to revitalize our primary healthcare centers, complete the general hospitals in our local government areas, and invest in our tertiary infrastructure. Our framework, in terms of time, is to decide whether we do this monthly or yearly, looking at the resources that is available and how feasible it is, looking at the 2x2 grid that WHO has proposed in terms of a high need, a low need, high feasible, or low feasibility. We want to thank you for the time that you have spent with us. And we know you have comments. We know you want to make contributions that will help Bayelsa State have a health system that addresses our problems and improve and give optimal outcomes to our population. Thank you very much.
Thank you very much, Dr. Okoye, for that presentation. I think we need to apologize that the slides were not too clear on this side. So you were not seeing the framework very well, but for emphasis, I'm going to repeat some of those points. Just to emphasize one, that this is a template, it's a framework. It's not a detailed improvement plan. So you don't expect all the details and elements of what we have in an improvement plan. That is a post-summit activity. Secondly, we have done a detailed SWOT analysis. And I think if you look at your bags, some of you have that SWOT analysis. We are trying to make additional copies of that SWOT analysis that gives an overview of all the health system building blocks, the strengths, the weaknesses, the threats, and the opportunities. And so we have that detail that I think they are trying to distribute it now. We can also send electronic copies to those that want it. Thirdly, what we presented as priorities challenges are just an element of what we feel, and based on discussions we have had at this meeting, what majority of participants feel that these are the major priority challenges of the Bayelsa health system. And some of these challenges relate to what we focus on in our national health policy and the global health agenda, which revolves around universal health coverage, primary health care, amongst others. So having given that background, let me also repeat that this improvement plan, for those that I cannot see, has components that include all the health system building blocks. We listed all the health system building blocks, and including partnership for health, research for health, and health security. So in addition to the 6 health building blocks, we included partnership for health, research for health, and health security. So the first column of the health system of that framework is the building block. The next column is where you identify the priority challenges of the Bayelsa health system as it relates to that building block. The next column talks about what is the baseline data for that priority challenge. Do we have a baseline data? The next column talks about the target. What are we targeting as a state, or what is the global target? The next one speaks to pre-intervention planning. For instance, an example was given here that we have infrastructural deficit in our states. As part of the planning, there's need for a detailed needs assessment. Because, for instance, secondary health facilities, tertiary health facilities in Bayelsa, we have not had a previous needs assessment for health infrastructural development. So that pre-planning is needs assessment. The next is what is the intervention that is required to improve infrastructure. This is an example. And we say the state requires a detailed health infrastructural master plan. And we also need to revamp our primary healthcare facilities, secondary health facilities to such an extent that you have one functional primary healthcare facility in every ward, one functional general hospital in every local government, and our tertiary hospitals are able to operate as tertiary hospitals. The next item there is the time frames. And so the improvement plan will identify the time frame for that priority challenge. Do we want to resolve it within 3 months, within 1 year, within 5 years, because it's a 10-year improvement plan, or within 10 years? The next item there is sustainability framework. For every intervention that we're going to implement, we must have a sustainability framework. It must be defined, because most of our interventions have failed because of lack of a sustainability framework. That's the next item there. Please, can you put up the slide again? The next item, I think, is the cost. The cost of this intervention that you're implementing. What is the cost? And so that is also a post-summit activity, because we can't determine the cost at this meeting. After the cost, the next item is the source of fund. Where are we going to get the fund from? Is it from government? Is it from the private sector, or from donor agencies? Then the last one is the M&E framework. that we expect to implement for that improvement plan that we have decided on. So this is open to discussions. It's a framework, so you can give us inputs and how to improve on it. And if you feel there are certain priority challenges that we need to identify and we must include as a post-summit activity, you let us know. So I would like to, my co-chair, Dr. Neni, will be moving around. I will give people opportunity to speak, but if you wish to write down anything, you just write it down. The time, we need to manage time. So if you are going to speak, 1 minute, please. 1 minute. So, well, we're trying to manage time. So as much as possible, make it brief, make it brief. So if you're speaking, make it brief. So we'll take comments.
Thank you, Mr. Chairman. I quickly want to refer us to page 3, on which you have a SWOT analysis of the commodities and products building block of the health systems. I think the use of the word commodities and products there denotes that the drugs and allied products that you use in treatment of people are just commodities that can be made available by anybody from anywhere and anyhow. So I am proposing that you change it to the appropriate words, drugs and pharmaceuticals. And that will help build more confidence in the products that you use. And I see somewhere here, it says that's under the threats, high infiltration of unlicensed medical products in the market. That presupposes that we have a weakness in the regulations. And we as a group, as pharmacists, we believe that we're in the best area to help you support, to give you support in this area of ensuring that falsified medicines do not get into our system. And of course, one of the ways we want to do that is to establish either a mini manufacturing lab with a fully equipped quality assurance that all medicines can go through. I believe that our population in Bayelsa is still not more than 3 million, and those who seek health services every day will be within a certain range. And therefore, if we have a mini lab or a quality assurance lab, I'm sure we can subject, if not all the pharmaceuticals that come in, but at least a majority of the pharmaceuticals can be subjected to quality analysis, and that will help us reduce these few of unlicensed medical products. I'm going to stop there for now. I'll study the document and I'll make more views. We move on. I have also already submitted a position to the chairman through my WhatsApp, and I'm sure he has seen it. Thank you very much.
Thank you, sir.
Thank you very much. Yesterday, I made a suggestion on health financing, actually concerning the amount of money to be funded to fund the primary health care. He gave an example of Rivers State, where he said they have 5 to 10% of the local government fund supporting the primary health care. I just want to make a suggestion that is it possible from this summit for us to come up with a law or a suggestion to the Ministry of Health, Federal Ministry of Health, to make sure that they incorporate this in their primary health care regulations or policies that will give access to all primary health care boards to be able to access at least 5 to 10% of the local government health funds to assist the primary health care boards. Thank you.
Sorry, let me give information. This is the first session where we're talking about improvement plan. The next session will be on the laws. So if you have any question related to laws, we can bring it up in the second session. So let's just talk about what we want to do, what we expect as the priorities for improvement.
Thank you very much, doctors and professors. I just want to make some few contributions with your permission, please. I would like you maybe to take into consideration the human resources for health. You know, when you look at what you are doing here, most of the workforce is under the umbrella of the ministry or state ministry of local government. Can I ask you one favor, like other states are doing? Let's request the move of these human resources for health from the primary health care to the state primary health care. Otherwise, you will never be in control of these people. You cannot make them accountable. You cannot judge anything. You will achieve nothing. This is my first suggestion. The second one, you need to conduct a training need assessment for these human resources based on what you have presented for the past 2 days. You have indicated that they need training, they need training, they need training. But which training? Put a kind of cadre, you know exactly the training need assessment you are conducting and which kind of training these people need. The number 3 is the issue of the equity agenda. Put it in your portfolio. You have said that 65% of your population is riverine. How can you access them? How? This means it's cover the number 4 question point I want to cover, the issue of logistics. There is no say about logistics in the whole plan. Please take that one. You have more logistic problem than anything else in Bayelsa here because it's accessibility problem. This is the main problem you are facing. The other thing is the issue of maintenance. Based on my hearing, for the past 2 days, you said that there are some equipment which were brought, they have never been used. Did I hear it well? Which means where is your maintenance? Where is your maintenance system? There is no maintenance. If you are developing a plan, develop a maintenance system coming from the primary health care up to the tertiary level. And you know that you have a logistic and maintenance system. Let me not maintain the mic for because I was given 1 minute. I would like you also to take into consideration the global, regional, and national goals, not for them to come and interfere into your program, which means you have taken into consideration all these global, national, regional goals in terms of eradication, control, and so on. Thank you very much.
Thank you very much. I'm Dr. Veronica Diane, consultant, restorative dental surgeon. I work with the Niger Delta University Teaching Hospital. I want to talk on the issue of oral health. Oral health as part of primary health care. When the primary health care board was about being established, we made a representation to the Bayelsa State Assembly on the inclusion of oral health in the primary health care board and primary health care in general, but it was not accepted. Now we have a problem where we train healthcare workers in Otwogidi, as their man was saying yesterday. They are being trained and they are not being utilized. If we don't include oral health care in primary health care, where will these people work? That's number 1. Number 2, Bayelsa State was created many years ago, I believe 1996. And Bayelsa was created out of Rivers State, being the smaller part of the state. We expected that Bayelsa State would develop faster than Rivers State. In the area of health, when Bayelsa State was created, healthcare facilities were abysmal. While other areas have been developed, the oral health has not been developed. That is, by now we expect that Bayelsa State should have a comprehensive dental hospital in Yenegua, and every local government should have at least a dental facility. In the wards, we can have also some dental inputs. This will curb quackery to a large extent. What is the essence of sending people for training when they cannot put into action the things that they have learned? So I'm recommending we are in the Nigerian Dental Association and the oral healthcare providers are recommending the establishment of a comprehensive dental hospital in Yenegua to cater for the oral needs of the indigenes, of the populace in Yenegua and Bayelsa State at large, and also dental hospital in every local government. Thank you.
Thank you so much. Following the line of the last speaker, I want to make an observation and a recommendation. Yesterday, when the VC of Bayelsa University, Bayelsa Medical University was analyzing some of the programs available, he itemized a lot of courses that were available there. And I was just thinking, if these courses have been operational, now let me learn proper. I am centering on, let there be an affiliation of products of College of Health to the University Direct. It is agreeable to observe that after graduating and after obtaining certificates, the highest HND, there is no direct progression to the university to study. Take the case of dental surgery technicians. As they finish their program with NC, there's no direct entry from dental surgery technician to maybe therapist or technology or surgeon. If you want to be a dental surgeon, you have to start from the beginning again. Take the case of medical lab, pharmacy technicians, and all the allied medical departments. There is no direct entry. So I am suggesting strongly that let this very platform make a recommendation that as they finish in this College of Health institutions, let there be direct entry. You can forfeit maybe 1 year, undergo 1 year, start from year 2, pharmacy, maybe pharmacy technician can forgo 1 year and start from 2. But it is pathetic to know that that is not being done. So let this very platform make a law that as they finish, there should be direct entry. Maybe because the boards have not been saying much, but if the state can take a leading role in this very aspect, I think it will go a long way. I think my point is somehow clear.
Thank you very much. I'm Tapfeng Mirabo of the College of Health Sciences. I want to crave your indulgence to permit me to stand on the existing protocol. My contribution comes in 2 folders. The number 1 is the quality management system. We are trying to develop a framework for health care improvement in Bayelsa State. I believe that, or I want to suggest that in the final draft, we should build in the quality management system. This will be the system that will enable us to monitor and evaluate our performance. We just finished listening to a lecture on the performance improvement. Number 2, I think we have to identify the task, which I believe is already done, and also allot time and responsibilities to them. Thank you.
Good afternoon. My name is David West, and I'm representing the Civil Liberties Organization of Nigeria. The observation I want to raise here, or we intend to raise as an organization, is why should it be that government will make efforts to get expensive medical equipment, and at the end of the day, it will turn out to be a problem to install those facilities for the use of people? If government had decided to go further to get this equipment, government should also do well to install it and train people to man it. The other observation we have also observed and we want to raise is, from the beginning of this program till this date, we observe that government is telling us about shortage of manpower, and as a result of which, the primary healthcare is suffering. Our recommendation to government is you have no option rather than to do recruitment of manpower. We don't want to hear fund is our challenge. Thank you very much.
Good afternoon, ladies and gentlemen. Permit me to stand on already established protocol. My name is Gatigo I. Clarkson. Please, sir, in this summit, to achieve a total health improvement plan, it is vital to consider all the pillars of primary health care. As it stands now, one of the pillars is not considered, most especially the public health aspects that are concerned with the safety of water, hygiene, food, and sanitation. Since the summit has started, this aspect, this pillar has never been reflected. Are not important towards the improvement plan of Bayelsa State? If yes, why? Thank you.
Okay, thank you very much for all the comments. We would also, in addition to what everybody has done, we want to just bring emphasis to what we feel, or we want to be sure about what you are in support of and what perhaps you are not in support of. So I will invite Nani. You want to do that? You want to do that, or you want me to do that? Or Dr. Ebika? Just for emphasis, don't know whether the screen will be clear enough. Okay, can you do it here? So just to say that we have noted everything that everybody has said. Again, most of what we will do is a post-summit activity. And it is, we believe that a committee will be set up where we get inputs from several stakeholders in the development of this improvement plan. And perhaps we will request for additional memoranda that relates to the improvement plan. So most of this effort will be post-summit, but we are taking some of the comments that has been made. And maybe the slide was not too clear because we actually addressed most of, even water, sanitation, and hygiene that somebody talked about was even addressed by this. So you will just briefly go through the priority challenges again for emphasis. Then if there are no additional comments, we can go to the next session.
Thank you, Mr. Chairman. Okay, just to, please bring your slide back. Okay. Just to remind us once more that we have also a strategic health development plan. And sometimes some of the comments could also reflect the fact that some of the issues are already in the strategic health development plan. And the framework is an attempt to use the building blocks of health systems. And that is the same framework that the strategic health development plan also uses. So we are adopting what we think will align with our national healthcare systems improvement pathway so that we don't deviate from what is a standard. So some of the things may not clearly come out as an item of isolation on its own, but because it is already built in under a building block. So I just needed to give that clarification. For governance, we looked at our priority challenges. That's the state health law. There's no state health law, which will address some of the things that some people have brought in here in terms of enacting a law that address a proportion of funds that should go to the primary healthcare board. So under this, that is already addressed. So if we enact that law, it will take care of that challenge. So the State Council on Health will also be something that needs to be addressed. So at least we have this forum, a summit where all stakeholders were able to discuss, dialogue, and chart a way forward. The State Health Council meetings will give that provision for us to review and then make recommendations for improvement in our healthcare system. And if you look at healthcare service delivery, it addresses some of the priority challenges that we have. But this is not cast on stone. That's why we have shared the SWOT across all stakeholders. And then this is largely a post-summit activity that will all bring in all the stakeholders further to develop the improvement plan that will address our needs. Thank you very much. Chairman, continue.
Okay, thank you very much. So I think in order not to overflow the issue, some of the questions that have been raised are actually addressed in these priority challenges, even performance management and so many other things. Can you go to the last slide? Let me just show them about the one before this one. The one before this one. Look at social determinants of health is also there. So we have looked at it comprehensively. Again, this is just a draft. Hopefully after the summit, stakeholders will be invited in the development of the improvement plan. So I want to appreciate everybody for your contributions. We have a session where we're going to present the summit resolutions, the definite summit resolutions, part of which is what we are discussing now, and other declarations and pledges that have been made by the Bayelsa state government so that we're all in one space about what we have agreed at the end of this summit. At this junction, I want to appreciate my co-chair, Dr. Edika Okoye and Dr. Neni, and everybody that has participated in this session, and want to now declare this session closed and invite the MC to take over. Thank you.
Thank you very much, Professor Dimio Ogoina and Dr. Okoyen, and of course the co-chair. Please put your hands together for all of them. And we have to say for a fact that they were absolutely time conscious, because most times it's Prof that is writing the papers and saying time up. So he had to watch himself too. Thank you very much. We'll move to the first one. Please, those on the projector, we had skipped the first one to take this one, so we'll now go to the first one. If you have the program plenary 7, the first one is development of a framework for the proposed State Health Act. Development of a framework for the proposed State Health Act. And our chair for this session is the Chairman House Committee on Health in the Bayelsa State House of Assembly, Dr. Onyike, God bless. Please put your hands together for him as he takes his seat. Please, you forgive him if you hear at some point those in favor say aye or those against say nay. You understand that is because he's a member of the House of Assembly. Thank you very much, sir. You can take the microphone and then invite your presenter. Please put your hands together for him again.
Good afternoon. My name is Onyike, God bless, I actually represent Sabama constituency 1 in the State House of Assembly. but I'm the chairman of the House Committee on Health. This part of the summit, for me, will be the first outcome that will be achieved by the state government, because the most important component, which is the political will, have been shown in this aspect. The governor has given a 3-month deadline for the ministry to submit to us. And I can assure you that when it gets to the assembly, we will do the needful. Even this morning, the speaker gave me his word to assure you that when that gets to us, we will do the needful. Dr. Abaye will be doing the presentation. He will do a rundown. It's a draft, just the sections, not necessarily the details. He will give us a broad the basic doctrines that will be covered by the law, not necessarily the full draft. Then Dr. Legemo is my co-chair. I don't know where is it. Okay, Pharmacist Daniel. So, Dr. Abaye, you can take it from there.
Good afternoon, ladies and gentlemen. My name is Dr. Bio Belu Abaye. I'm the Bayelsa State epidemiologist, and I am working with a team to begin to draft the new Bayelsa health law. So today I'll be presenting to us just a framework of what we intend to eventually become our Bayelsa State health law. So like I said, it's a framework. We'll be discussing structural issues, sectional issues of the law, and post-summit, we'll be looking at the details. Once again, you're welcome. Wow. Okay, essentially in trying to draft a health law, we will be looking at the entire health system structure, and we'll be addressing laws that will help each of those segments to work. And as you can see from the diagram here, we will be looking at all the health blocks, all the building blocks for health. And these building blocks for health are already being addressed in the strategic plan. I would like to look at the building blocks for health in 3 broad classes. One is the public health system. The other is the healthcare delivery system, which is largely hospitals and healthcare centers. And then we'll also look at other support services. So this law will be addressing them in this kind of sectional outlook. And of course, all of this will be strengthening the strategic health system development plan. Of course, in the plan, we are considering 2 critical things that will help the strategic plan to work and be sustainable. And that is the law and the partnerships involved. So that's what we'll be looking at in some detail. Now, to talk about the law in itself, I said it will be in different parts, addressing different aspects of the health system. So first of all, by way of introduction, the state health law will enable the provision, regulation, management, and development of the health system for Bayelsa State, and also set standards for rendering health services or other related matters in the state. Well, to really bring this to pass, we will be setting up and we will require visionary, careful, collective, and concerted work. People who have these qualities will be brought on board. People who may even think they are left out will be brought on board, because it's going to be a collective and concerted work. And we'll bring subject matter experts in various sectors, not only in the health sector. Several sectors will be involved in the final draft. So this I'm about to present is going to be the framework. Why do we need a State Health Act? And what are some of our key assumptions in drafting this law? First of all, the National Health Act needs to be domesticated in some ways in states. And Bayelsa would like to be among the first states to achieve that. So we want to have a state health law that mirrors or at least adapts some of the sections of the national health law. Secondly, there are either no frameworks or regulations in place presently, or they may be outdated and need to be reviewed to ensure relevance and ease of implementation. We also assume that the health law will protect strategic plans. We're talking about a 10-year strategic plan. This has to be protected and strengthened by a law. And of course, other issues about health programs will also be strengthened by the law. Fourthly, a legal framework like this health law will direct all concerned to collectively pursue and sustain health-related SDGs. We also expect that the health law will also help healthcare providers to conduct themselves in a professional and ethical manner, because they are spelled out punitive actions that may follow violations. And finally, we will ensure that the law provides protection for users of the health system as well as providers of healthcare services and products in the state. So in view of this backdrop, we have 6 objectives for drafting this law or asking for a law. One is to provide regulations, policy for the state health system. Secondly, to protect the strategic plans and even micro plans in the health system. Thirdly, is to direct the pursuance and achievement of SDGs and to provide a legal framework for Bayelsa to pursue its own health security agenda. Fifthly, is to define and promote professionalism among healthcare providers. And of course, finally, to protect the rights of users and providers. So this just talks a little about the health system. And in this law, particularly, I would like you to look at the blue part. In this law, we will try to emphasize classifying all healthcare providers and regulating them appropriately. Because we do not want private facilities, for instance, to just be labeled private. There are some of them that are just primary healthcare centers. There are others that are actually close to being called tertiary healthcare centers. And we will, by this law, enable the Ministry of Health to properly classify and as such, regulate their activities accordingly. So the framework of this document, as many similar documents are, will be made in sections. First of all, you have 8 parts. This law may be 8 or more parts, and each of the parts have chapters under them, and each of the chapters will have sections under them. And of course, some of them will have subsections as well. Okay. All right, so these are the 8 parts, essentially. I would like us to just take a moment to look at it carefully. Part 1 talks about the establishment of the state health systems, of the state health system, essentially, as well as talking about responsibility for health and eligibility for health services. Now, these 8 parts have been adapted from the National Health Act, and we are going to try our best to tailor it to Bayelsa needs, call out the things that are relevant to Bayelsa, add what is peculiar to Bayelsa, and not necessarily repeat what is already provided in the National Health Act. For instance, we may just need to refer that we will uphold so-so section of the National Health Act while we go into details about those we consider to be peculiar to Bayelsa State, so that we avoid unnecessary duplication or repetitions. And of course, waste of paper and further deforestation of the Niger Delta. And the second part, of course, we'll talk about the Bayelsa State establishments and healthcare establishments and technologies. There we'll be looking at facilities and their modes of operation and the technologies they apply. These will be classified, and we'll look at some details shortly before I end this presentation. The third part will be on the rights and obligations of users of the health system and providers in the health system, healthcare personnel. The fourth part will be the state health information system and will be on the state health information system and health research. This is very important, very critical, very dear to our overall improvement plan, and we need a law or segments of the law to address what is peculiar to Bayelsa. Part 5 talks about human resources for health in Bayelsa. We will address issues of training and other human resource deployment issues. And then part 6, I beg your pardon, we will be addressing mainly the regulation of alternative medicine and healthcare delivery in non-healthcare facilities. And of course, we may glean some aspects of the national health law on the control and use of blood products, tissues, and other things, similar things. Part 7, as you can see, we'll be talking about public health, essentially. So in part 7, we hope to exhaustively deal with public health laws, public health establishments, and allied establishments. And the 8th part will be on partnership regulations. One of the emphases of this summit is on strengthening partnerships for development. And so we'll be putting in our law clear guidelines, clear laws that will enable partners to come, work, benefit, as well as provide benefits for our people and other miscellaneous provisions. So in trying to go through a little detail, we are going to tweak these details, and I'll just run through them because it's not a final draft. It's just to give you an idea of the work that has begun and give you an idea of areas where you may need to begin to send us memoranda, send us your opinions, send us your suggestions. So permit me to use another 10 minutes to run through some chapters in each of these parts. Part 1 on the establishment of the Bayelsa State Health System, responsibility for health and eligibility for health services. Chapter 1 will talk about a clear statement and declaration of the establishment, components, and structure of the Bayelsa State Health System. It will be spelled out. We'll also talk about the structure and functions of the State Ministry of Health. There are documents related to this, and this law will just improve upon them and make them more relevant to current realities. Chapter 3 will talk about the structure and functions and components of the Bayelsa State Health System. I think that's a continuation of number 1. And chapter 4 will talk about the eligibility for exemption from payment for health services in public health establishments. This will also imply there may be no law exempting anybody from payment in the private facilities. Still in part 1, chapter 5 will talk about the establishment, composition, and functions of the Bayelsa State Council on Health. This is novel, and we eagerly look forward to it happening this year. Establishment also, composition and functions of the technical committee on the Bayelsa State Council for Health. So we'll have a council for health, and we'll have a technical committee for the council, which is recommended by national laws. Chapter 7 will talk about the conduct of the proceedings of the technical committee, because there are procedures for how they will work and how they will function in the space of the Council for Health and in the space of the health law. Chapter 8 will talk about the establishment and functions of the Bayelsa State Tertiary Health Institution Standards Committee. I heard somebody mention that of the national here, I believe. Is it still here? Somebody mentioned that of the national, and we want to ensure that in view of more expanded tertiary education in Nigeria, especially in health training, healthcare training, we want to ensure that this committee is functional with this law. Chapter 9, we have 12 chapters in this first part, probably more or less as the development of this document continues. Chapter 9 will talk about the establishment of the Bayelsa State Healthcare Standards and Certifications Committee. This is a very important committee as we look into the issues of standards and quackery and all the rest. Chapter 10 will talk about the establishment of the Bayelsa State Basic Healthcare Provision Fund, which is a recommendation of the national law. But in addition to this, we'll look at the possibility of having another fund for other aspects of our health system. And so for now, we have called it the establishment of the Bayelsa State Health Intervention Fund. And this will cover possibly other things like public health emergencies and other similar things that are not covered in the Basic Healthcare Provision Fund. Chapter 12, still in part 1, the last chapter in part 1, will be the establishment, of course, of the already existing BHIS, which this law will just back up. Part 2 on the established healthcare establishments and technologies has just 5 chapters. Listing and classification of healthcare establishments and technologies. We must list them. We must spell them out. This is where we will really need a lot of inputs so that we don't leave out anyone on the list. Chapter 2 will spell out the certification standards which the earlier mentioned committee will enforce. What are these standards? What do they cover? And then the committee earlier mentioned will implement. Chapter 3 talks about the offenses and penalties in respect to the certification standards. And chapter 4, provision of health services in public establishment. And the last, chapter 5, provision of similar services in private establishments. Part 2 still continues, I beg your pardon. Healthcare services at non-health establishments and at public or private healthcare establishments that may not be hospitals. Now, this is important, especially in our settings, and fortunately it's in the national law, so we may be bringing out specifics that relate to us. Number 7, chapter 7 here talks about emergency services, evacuations, and referrals between the healthcare system. This chapter is dear to us in view of the revitalization of the emergency medical services in the state. Chapter 8, relationship between public and private health establishments. We need to talk about this. How will they relate? How will they collaborate? How will they carry out services ultimately for the good of the people? There have been a lot of connectivity problems, disconnect between their services, and even the referral of patients. And chapter 9, evaluating services of healthcare establishments. And this is where a lot of evaluation, M&E, and all of that will come in, and we'll be spelling them out. Chapter 3, rights and obligations of users. We talk about general rights, emergency treatment rights, indemnity and healthcare provider indemnity of the healthcare provider, officer, or employee of a healthcare establishment, rights of user to have full knowledge, duty to divulge or disseminate information. And in this also, we have included some issues that concern the pharmaceuticals also. We'll also look in this part, chapter 9, we'll be talking about obligation to keep record. So it will become an offense for a healthcare provider not to have appropriate records, as we often see today. Confidentiality and other ethical issues, access to records by healthcare users and healthcare providers, storage and protection of these records, and how complaints will be laid and managed. Part 4 has a number of chapters also. Has 7 chapters. The establishment and functions of the Bayelsa State Health Research and Ethics Committee. We understand there is a committee now, but we'll be giving a stronger legal backing and structure to that committee to bring it to higher standards. Number 2, composition and tenure of the State Health Research and Ethics Committee. Who will be members of this committee? Is it only civil servants in the Ministry of Health? We will be talking about this together with your inputs and put it down in this law. Research and experimentation with human subjects will be addressed, or perhaps we'll just allude to the existing national law. And coordination of the health information system in the state, duties of the Ministry of Health concerning health information, duties of local government, duties of healthcare providers. Part 5 will be dealing with the development and provision of health resources in the state health system. Appropriate distribution of healthcare. Now, remember that part 5 talks about human resources for health. So everything that needs to be legislated concerning human resource for health should be considered here. So this may not be an exhaustive list, as you can see. Part 6, of course, we'll be dwelling a lot on alternative medicine here and just allude to existing national laws concerning blood, tissue, and other things like that. So here we'll be talking about blood transfusion services need to be strong, probably even stronger than the emergency medical services, or at least as strong, and so on and so forth. We will also define and regulate alternative medicine practice in humans. Yeah. Part 7 is where we'll be dwelling more on public health laws. So this is a very extensive chapter, and we call on everyone here, as soon as the conference is over, begin to find out how you can send in your inputs to all of these chapters, and especially this one. With the COVID-19 pandemic just very much, in our memory, we will need to look at a lot of public health regulations in this law. So we'll be providing for the establishment of public health departments, parastatals, and agencies according to need, listing and constitution of public health establishments in the state, other allied public health establishments in the state, and more recently, the establishment and functions of the Bayelsa Center for Disease Control, which of course will be established by its own law, but this law will give a foundational backing to that. And of course, the powers of the executive governor of the state to establish or dissolve government-owned public health institutions. The last chapter, chapter 8, will spell out a lot of partnership issues, which will include regulations for health-related synergies and collaborations among government establishments. And then it will also talk about partnerships between government and non-government organizations, both local and international. And of course, issues around the power of the Honorable Commissioner to set up boards. Those are miscellaneous provisions other than partnerships. Of course, we'll talk about the Bayelsa State Consultative Health Forum. This is a forum we will be recommending a periodicity of their meetings. It's different from the Council on Health. The Council on Health is a smaller team. The Consultative Forum may be a crowd like this on a periodic basis. The assignment of duties and delegations of their powers, and of course, we'll be looking at other issues of asset management, liabilities, and handover or transition provisions. Lots of handovers have been haphazard or non-existent. The law will now make it an offense to hand over improperly. So the law will also contain a lot of organograms, structural diagrams, conceptual frameworks, and so on and so forth, and we'll acknowledge all those who have sent in contributions to the final draft. Once again, I want to say a big thank you for your time. I hope that this framework will help everyone here to make inputs to the final draft. Remember, the executive governor of the state, His Excellency, Senator Doye Diri, has mandated that in 3 months, the final draft should be made available at least to the House of Assembly, if not to him already. So we are going to start work immediately after this conference, and we call on all of you to please support us with your inputs. Don't feel left out. Talk to your colleagues who are not here, and please, let's get Bayelsa the best out of a law. Thank you very much.
Thank you, Dr. Abia. Yeah, this is a very novel way of making laws. Normally, when we make laws, we wait for the law to get to the assembly and we do first and second reading before we call for public hearings. But the ministry have carried us along from the beginning, from the drafting stage. You see, this law is very important. Last year, when we were at the peak of the COVID crisis, the governor was looking for where to derive powers to restrict movement and the rest. And we had to rely on the 1926 Spanish flu law edit to get an executive order to restrict movement. And as parliamentarians, we ate executive orders because I believe it mitigates or reduces the power of parliament. So then I was thinking, let's get a law, but we had COVID crisis, we cannot meet. Members were not confident of themselves if they are positive or not. So we have to use it in order to achieve that. Now we have the opportunity to sit down and make a proper law in the amendment, the public health section of this law. We'll do that. I think where we have contention, and I feel members of the agenda should know for now, is the issue of funding, the issue of the basic health fund, the intervention fund, because you have to tax state government, there have to be a percentage, there have to be a lot of negotiation to achieve that. And I'm also thinking if we can also add a composite column to see how we can say, okay, you cannot appropriate less than 5% of your budget for health, like the Abuja declaration. But that will be tough. That will be tough. So we should be open to that and see how we can discuss with the executive and work that out. I will hand over to my colleague, Pharmacist Daniel, to take discussions and thank you. Thank you, Mr. Chairman. And I want to congratulate Dr. Abaye for his beautiful, well thought out presentation. I think in addition to being a medical doctor, maybe you also ought to be in the assembly. Even the assemblyman could not have done better than this. While I was jotting a few things down, I even went down to the level of draftsmanship and all of that, which I believe we're going to get to. To set the tone for our discussion, Dr. Lemo will be taking the microphones round. So those who will want to make inputs, but I think we need to just set some few ground rules now. We'll allow 2, 3, no, let's say 4 people at not more than 2 minutes each. So you'll be number 1, 2, 3, 4. Other people, sorry, for want of time, please put down your comments on paper. Somebody will go around it and then we'll try as much as possible. So number 1, 2, 3, and 4. So for other people, you take, put down your questions or your contributions. And if we have time, we'll still call you. Thank you very much.
Thank you very much for finding my hand this time. My name is Christian Okeju. I want to observe that yesterday when we were having this discussion, we made categorically that PAC under one roof is one of the issues that we needed to address in this gathering. And looking at the presentation, I saw where things like that came up in chapter 2. So it is my personal opinion that this chapter 2 should equally address PAC under one roof so that we can make progress in primary health care. Thank you very much.
Thank you very much for that beautiful rendition by Dr. Abaye. I'm Dr. Amatare Dian. I'm a consultant, anatomic and forensic pathologist. Looking through the proposed rules, I want to ask, what place do we have the corona laws in place in this, in Bayelsa? I know we don't really have an existing one. Even in Nigeria, I think it's only Lagos State that have sat down to draft a corona law. So there are a lot of deaths in Bayelsa now that are being swept under the carpet because we don't have the corona law in place. So what plans do we have to really have the corona law in place pertaining to autopsies and the handling of forensic matters in Bayelsa State? Thank you.
Thank you very much. I will keep it very brief. My name is Dr. Biamo Bikez, a consultant community physician, FMC Yenagua. I'm thinking of some of the things we mentioned yesterday, creating an equity fund, a platform that will enable the state to actually make a business case to raising their fiscal space for health. World Bank, JICA, a lot of countries and individuals can actually, foundations can pay money into that place to help the indigent or to help those who cannot pay premium for their own health insurance. So I'm suggesting that the team may have to create an equity fund as it exists in other states' health insurance law. Thank you.
Thank you very much. A well-elaborated document. I think maybe I have missed one of the points, but looking at your building blocks, I would like to know where is the place of the family, the beneficiaries. You are talking system, but you are not talking about the beneficiaries, your target. We're talking about that one. There is one sensitive target, which is a priority of the priority. I think I'm a former UNICEF staff. Sorry, I'm a retiree from that before being engaged by Gavi. Just to tell you about the issue of the Child Rights Act. There is no Child Rights Act here. Where is it? You have to take that one, because if you take that one, it will be a kind of enabler to drive all the family care issue. You understand? Because nobody will come to say, if to indicate to a mother and a father that it's a right for the child to be immunized, it's a right for the child to be to attend this and these services, it's a right for the child to be breastfed for 2 years, and so on and so forth. The second one is the issue of make it a little bit wider, the community ownership. There is a say in Africa, they say that the time when they are washing your back, wash your tummy. You cannot replace the community. If there is no community ownership inside it, I am so sorry, you will be missing the target. I recall in 2010 when I was discussing with one commissioner for health, or the commissioner for health of Cross River, when he built these 200, they built close to 300 PSCs and all of these things. I say, you have built something, but this one will vanish, which has happened in less than 18 months. Why and how? Everything was set for the community, but there was no community participation into it, no community ownership. There was the building, equipment, personnel, and everything, but they did not say, this is yours. Huh? Where is it? Put it. The third one, okay, is the issue of the multi-sectoriality. You know, we health professionals, we always think narrowly. Think about the people from the Ministry of Water Resources. I think one person has said it already. The Ministry of Women Affairs and so on and so forth, which law allowed this one to step into the health sector to contribute in the health sector development. Lastly, sorry for taking long, is the waste management issue. I did not see anything talking about the healthcare waste management. Where is the healthcare waste management in Bayelsa? You see, we are doing, for example, immunization campaign, nowhere to burn it, nowhere to destroy. Okay, take it into consideration for your own development. Thank you.
Thank you very much. Please, for want of time, we'll just take one more question before we give Dr. Abaye the opportunity to answer. We also have 2 other questions. We'll also take other rounds of questions so that we don't lose touch of it. Please, Chairman, please, within 2 minutes, please. Thank you.
Very brief. Thank you very much. I'm the chairman by Bayelsa State Primary Health Board. I'm talking about after this summit, if we can just come up with 2 laws or policies. One concerning maternal child health care. And what do we want? I'm talking about people who are going for ANCs and our children 0 to 5. Can we have a policy that will enable them to be able to walk into any of our health centers, any of our health facilities, and get free medical health care? Even if you want to put something with the basic health, Bayelsa State Health Care, Bayelsa State Insurance Fund, let us make sure that our children 0 to 5 are able to work, get into any health facility and get free health care. That's one of the problems that we are facing in this state. Then the second one I spoke about earlier was making sure that the local government area
laws and how that affects this law. And then, of course, I think one of the speakers, the chairman of the Primary Health Care Board, talked about health policy. Yes, we were told that we need to look at the state health policy as another part separate from the law. So it's something we are already considering going forward. And what percentage will be pledged to will be stipulated from the state funds for primary health care and all of that. It's being discussed. All kinds of percentages are being discussed. And of course, the feasibility will be finally done by the economic experts and the team from the executive governor. So it's something that we already enjoy the directive and the political will of the executive governor, and I'm sure all these issues will be considered. For this first draft, it was essentially drafted by about 3 persons, which I led, but we know that this is just to ensure that this matter is on the front burner in the summit. It doesn't make us the final writers. It doesn't make us the only contributors. So going forward, we are going to do more than this. The law is also in listing and discussing healthcare establishments, their functions and all of that. We will also look at the existing laws or existing policies about boards, and we'll make sure, let's rest assured that with the thinking already in place, and the inputs we believe will be coming from you. There will be no duplicity, there will be no contradictions, there will be no clashes in existing policy and the planned policies, and we trust that by the grace of God, we will have a standard law that will take us a long way in our health systems development. Thank you, sir. Let me over to the chairman.
Thank you. Let me just say that no law can actually address everything. We actually have laws for health insurance. We can amend that law and deal with that. There's the child rights law already in the state. We can amend that and deal with some of the issues. So we can't put everything in the health law of the state.
Okay, thank you very much. So we've looked at some of the questions and the comments that have come in. There are comments concerning specific things to be included in the law. Please, let's also remember that this is just the framework. We will call post-summit. There are post-summit activities where all critical stakeholders, every single one will be invited to make an input into the body of this law. In these meetings, that is when we are going to be discussing the body of the law, the things to put into the law. So please be rest assured, everyone will be carried along. Every institution will be carried along. Every stakeholder, community, and everyone. So the Honorable, the Executive Governor has given a mandate that this law should reach the House of Assembly in the next 3 months. And the Honorable Commissioner is committed to it. Therefore, every stakeholder will be informed, will be invited post-summit. So thank you very much for this section. We want to thank the chair of this section, the House Committee Chairman of Health, and my chair, the rapporteurs, and especially the presenter, Dr. Bello Abaye, for his presentation. Thank you all for your kind attention and participation.
So we have come to the end of this segment. I have the permission of the chairman. We are going to actually appreciate Dr. Abaye for this beautiful work that he has done. Please, can we have a very resounding round of applause for him? I'm sure if he doesn't have a PhD in law, he should probably go and do a PhD in legal systems. Having said that, ladies and gentlemen, I think it's important to also know that no one single law can capture every aspect of anything. And then we need to also develop guidelines and policies. Guidelines and policies can be gazetted and be as good as laws, as good as regulations. And they will guide specific areas and aspects of the operations of the health system. But what is most important, which Dr. Abaye did not also lay emphasis on, the area of sanctions. We have incentivized a lot of people in Nigeria, but what do we have? We have had people who have used those incentives against the populace. I think it's now time to try the opposite. Okay? Try the opposite. Put a sanction. Let's see whether those sanctions will work. If you fail, we'll give you this so that others can follow what is right. So on that note, ladies and gentlemen, we have come to the end of this session. I want to say thank you for listening. Thank you for being with us. And see you post-summit, where we will all sit down again to look at these laws. And I believe that we're going to have a house as full as this. And all stakeholders, including myself, will be there to put in to make our inputs for the betterment of Bayelsa State and for the glory of God. Thank you very much.
Thank you very much, sir. The chair will have group photographs now. The presenter, the co-chair, please. Prof, please join them. Distinguished ladies and gentlemen, shall we please come back to our seats as we take the closing part of this summit. It's been a wonderful 3-day event, and this is the grand finale. I'd like to welcome to take the resolutions, present the resolutions to us if it's ready, Dr. Chijioke Kaduru. Please put your hands together for Dr. Chijioke as he comes to present the summit resolutions.
Thank you very much. Good afternoon once again. The Permanent Secretary, State Ministry of Health, Bayelsa State, the Chairman of the Local Organizing Committee, all of our distinguished guests that are still here with us today. We'd really like to go ahead to walk through some of the conversations that we've had over the last few days and some of the resolutions that have come out of those conversations, as well as open up an opportunity to also get feedback and input to make sure that we build consensus around all of the different resolutions that have come out so far from our conversations. So the summit has held from the 19th to the 21st of April. And we started out with a key focus on a health system situational analysis for Bayelsa State and a key proposal for health systems reform, which were presented at the opening ceremony. Across the first day of the summit, we had a total of 726 participants on the first day, spanning across a wide range of stakeholders, including representatives from the federal government, the state government, looking at the executive and the legislative arms of government, traditional rulers, community leaders, civil society organizations, religious leaders, implementing partners that work across national and the different states, as well as key health sector players that include the professional associations that work in Bayelsa and beyond. What we had here across our stakeholders was a good crop of all of the key people who matter in health at all the different levels in Nigeria and in Bayelsa State. Now, beyond the opening ceremony and going on to the second day, we had around 422 participants for yesterday, and we're still collating the final numbers for participants today. We've been able to walk through 7 different plenary sessions, 5 panel discussions, as well as 2 expert presentations in line with all of the different parallel sessions that we also had going on throughout the summit. Based on the discussions from the opening ceremony, we had key policy commitments from His Excellency, the Executive Governor of Bayelsa State, around completing the referral hospitals in Sagbama, Ikeremo, Ogbia, and Oporoma within this fiscal year. We had a commitment to build and equip a new general hospital in each of the 8 local government areas of the state during the duration of this administration. We also had commitments to increase coverage of the Bayelsa Health Insurance Scheme in the informal sector, as well as a commitment to strengthen the immunization and safe motherhood programs at primary healthcare level. We also had additional commitments around legal reform of the health sector through a state health law, which will be presented to the State House of Assembly by July 2021. We had commitments that the state will provide counterpart funding for partnerships to deliver health services, including emergency medical services, primary healthcare revitalization, prioritizing high impact reproductive, maternal, newborn, and child health and issues. Of course, we had the launch of the new emergency medical services and ambulance system for the state, as prescribed by the Basic Healthcare Provision Fund operational guidelines. And we had a commitment to operationalize the Bayelsa State Center for Disease Control by July 2022. Now, we also had other key resolutions around an agreement on a time frame for the operationalization of the Bayelsa Emergency Medical Services and ambulance systems. We agreed on a dissemination of the health system's performance improvement plan to all partners, particularly highlighting government's commitments to facilitate partner support. We agreed that there's a need to strengthen interagency coordination across all of the different health institutions in the state. We agreed as well that we would roll out an expanded private sector support mechanism led by the state and working with stakeholders from the organized private sector, as well as all other critical stakeholders in the health system. Now, we also resolved to develop and implement program and financial accountability mechanisms to strengthen partner confidence and buy-in. We resolved that there's a need for investment in closing the primary healthcare infrastructure gap in the state using the modified PHC design plan that includes accommodation structures at primary healthcare level. We also agreed to work to secure full accreditation for the Bayelsa Medical University for its medical training. We did agree to conduct community validation of the health systems improvement plan to make sure that there is a community view that goes beyond the community participation that we've had at this summit. We agreed to commence full implementation of the Work Development Committee system with quarterly meetings of the committee and primary healthcare workers. We also agreed that all state strategies for health service delivery will prioritize integration and resource efficiencies towards delivering an agreed minimum package of services in the state. We resolved that we would conduct a health worker needs assessment and also a training needs assessment for all levels of healthcare within the state. We agreed to review and strengthen the systems for recruitment, remuneration, and retention of community health workers. We agreed to effect the redistribution of PHC workers by July 2021 and to develop and implement an accountability mechanism for PHC workers. We agreed to develop a revised system of incentivization on rural postings for highly skilled workers to support the existing community health workers. We also agreed that we will develop and implement strategies for sustainable in-service training, especially for primary healthcare workers. Now, we agreed that we would need to develop and implement a fully integrated logistics and supply chain system for vaccines and all public health commodities, as well as develop state plans for procurement, plan preventive maintenance and corrective maintenance of warehouses, storage equipment, delivery vehicles, and delivery boats, and to expand the minimum package of primary healthcare services to also include oral health services. We agreed that there's a need to design and implement a quality management system for health facilities across all the different levels of care, and to develop a mechanism for biannual reaccreditation of all health facilities in the state, and a mechanism for annual health facility assessments in the state. We also resolved that we would establish a research fund working with the private sector to catalyze local research and strengthen in-house research capacity in the state, and to develop and implement a mechanism for presentation of research from the health sector to support development of annual operational plans. So those are the key resolutions that we've been able to capture across all of the different sessions, plenaries, conversations that we've held over the last 3 days of the summit. At this point, we would also would like to welcome comments and feedback across all of the different participants here, because ultimately the resolutions would have to reflect our consensus across the entirety of the summit. Thank you very much for giving me the opportunity to present these resolutions, and we'll welcome your questions and comments.
Okay. All right. So let me. I think this was really it's quite a great effort, and I commend my brother for the presentation. Just a quick one.
Oh, my name. Oh, okay. I am Dr. Eric Mwaze. I am the Zonal Director for National Primary Healthcare Development Agency, Southeast. All right, so I was just commending the presentation, just a very quick one. I like the way the state epidemiologists classified everything we've done. For this to be very smart, I think I would like to see 3 or 4 headings, because it's like, I mean, the points have been made, but I think it's good you group them into subheadings, because we have succeeded in looking at the entire health system. So he did classify it into public health, under which you have PHC, and that was really good. And then medical services, under which you had secondary and tertiary tier, which is what we have done. And then the third one, supporting system, other health-related systems. That is wider determinants of health. So I think that will be done. Then secondly, and perhaps the most important, this is supposed to reflect our consensus. Unfortunately, we haven't really worked in tracks or groups to be able to say we have harvested inputs from the House. That's a slight minus, but there is a way we can correct it by actually projecting the various slides and having people comment on it, so that at the end of the day, we can be happy to say that this is actually our resolutions and we own it. The way it is, I have a little fear, because it's like individual presentations from key people, professors, as good as they may be, but I'm not too sure that it actually captured the inputs from the audience, you and I, sufficiently. I don't know if anyone noticed that. I'm sorry if, yeah. So I would like us to look at the various sections and invite people to say whether they agree or disagree or amend the various bullets. And when it is amended, it has to be captured on the floor of the meeting. That's the only way you can say we own it and it's our own decisions. Otherwise, it will be like we have just stamped the opinion of some key speakers, which shouldn't be so. This is a health summit. Thank you.
Let's keep it to 1 minute so we can go around. We have so many questions.
Thank you very much. I'm Dr. Veronica Diane. I work with the Niger Delta University Teaching Hospital as a consultant. I quite agree with him. I was wondering when we agreed on some of these things. When you said we agreed that, we agreed that, we agreed, and I was wondering if we are actually going to group them, then my comments, I'll just limit it to 1. I don't know if we are going to group them and discuss later. But if not, let me just make my comment. I remember there was one that shook me in particular, talking about training, that we agreed that we should, government should fund, is it postgraduate training or something for BMU? And I was wondering that, is it? No, there's something like that. Accreditation, okay. Government should fund accreditation for BMU. And I was wondering that if you are funding accreditation for BMU, what happens to NDU? We just held accreditation yesterday, and it's still ongoing. So we need to be funded. That's what we are saying. Funding for accreditation should come from the government for all the institutions, not just for one particular institution. Thank you.
Thank you, madam. I will just go straight to the point. My name is Chief Matthew Akoibi, DSNO Sagbama. I have a very serious concern. I think I should give it now. What is my concern? We are talking about employment of health workers at the local government. And the people that are saddled with their responsibilities are not invited. So my advice is this: going forward, when they will prepare for the post-summit, the 8 local government chairmen should be invited to this arena to address the issue of unemployment of health workers at the 3rd tier. Thank you.
Hello, I am High Chief Dr. Solomon Ederia Ginaya. I am the Director of Medical Laboratory Service, Federal Medical Center. When we talk about PAC, the laboratory component is always missing. And for any empirical evidence for treatment, the laboratory must be involved. So I'm using this opportunity to say that the laboratory component of the PAC should all be strengthened so that people will get the best. Thank you.
Hello, please, can I, let's just make a comment, please. I think just to guide us and to save time, let us go to the slide, take it one after the other, and just agree. It'll be better that way. Let's do it that way. So that if we have comments, we can make specific comments. But if we're making comments in random, we'll still waste time. So let's go to the slides, take it one after the other, and if we have the adjustments, we'll make that.
So I've told them to put it on a full screen so that it's clear and it's easier for people to see. So I'll just read through them one after the other and would walk through our consensus around each issue so that we're able to make the necessary edits across board. So the first thing that we have here from our conversations is on a time frame for the operationalization of the emergency medical services and ambulance system. So we have consensus that during that session yesterday, they did agree on a time frame with the Federal Ministry of Health around which we will then operationalize that new system. The next point is on the dissemination of the health systems improvement plan, which we agreed that at the end of the post-summit processes that generate that plan, it will be disseminated across all of these different stakeholders. We also resolved around strengthening interagency coordination across all of the different health institutions in the state. So do we all agree that we want to strengthen interagency coordination across all the health institutions in the state? Do we all agree that we need to roll out an expanded private sector support mechanism, working with stakeholders from the organized private sector? Do we all agree that we need to develop and implement a program and financial accountability mechanisms across all our work?
Now, look, this resolution. Why do we need to have resolutions? This is an advocacy tool, right? This is what is going to be shared to policymakers and say that this is what these guys came out with after this kind of meeting. For us to say we agreed on a time frame for operational, the next question the governor, whoever will ask is, when will it be? So this is not an action. It's not an action point. What does it say that you agreed on a time frame? If it is me, I will naturally ask you, when will that be? But if you say, if you are able to state the time that we have agreed, then it becomes smart. Because each point has to be smart. Otherwise, it becomes a loose number of bullet points that will not draw action. You want to use this to draw action of somebody or a policymaker. Even the second one, agreed on the dissemination of health system be formal. What have we been doing? Have we not been doing that? Hello? Have we not been doing that? So we want something out of the usual that you want policymakers to draw support so that we can move forward. So we can retain the last three, but for me, the first two is my opinion, is neither here nor there.
All right, so are there any other comments or suggestions around those? I mean, excluding the comment around including a definite time frame for both of them. Are there any other comments? All right, so we would revert to the rapporteur reports from those two sessions and get the exact time frames that were stated in those and be able to revise those statements accordingly so that they clearly reflect the time frames that were agreed in those sessions. So I'm going to move on to the next slide that we have around the resolutions. So we resolved that we would need to close, or we need to invest in closing the primary healthcare infrastructure gap in the state, particularly around making sure that we are able to work towards including accommodation structures in all primary healthcare centers. Do we agree that that's consensus that we came to? Are there any additional or opposing comments around that? So again, we will revert to the rapporteur notes and agree on a time frame unless we have a suggested time frame. Because the only consensus that we had was that within our 10-year health systems improvement plan, we'll close that gap. But we'll revert to the notes to see if there are any more specifics, unless there are suggestions here that will guide that conversation.
Well, some of these resolutions that have been stated may not necessarily have a timeline, except the timeline has been agreed by the governor. So even if we discuss a timeline in some of our meetings, those timelines may not pass because they will be subject to post-summit analysis. So the timeline that we may have to fix here are the timelines that the governor has made himself. So what we will have to say is that we are making these plans, but I don't think we can commit to a timeline at this meeting because there are so many things involved in timelines. So please, let's leave, apart from the one that the governor has committed to, there will be no other timeline that we can agree at this meeting. It has to be a post-summit activity. Thank you very much.
So,
Good afternoon, ladies and gentlemen, all protocols duly observed. My name is Possible Ominibo. As part of my suggestion to the smooth running of this resolution, I have something to suggest that will be of benefit to the clinicians and to Bayelsa State as a whole. I think at this point in time, we should be talking about having post-basic programs for our nurses and our doctors. Programs like emergency nursing or anesthesia. I think if we have this program, instead of a nurse, I'm a nurse by profession, instead of a nurse traveling to Port Harcourt or going to University of Benin Teaching Hospital to spend the money to their states, if we have these programs here, that money will be paid into Bayelsa State government account and it will be of help to this state. It is a suggestion that will help Bayelsa State.
Can I advise that let's first focus on what we have here. Let's focus on what we have here. If we have concluded this, then you can make your additional suggestions so that we don't go back and forth.
Thank you,
Please,
sir.
let us focus on what we have here. If you have specific comments on this, otherwise, if you have additional outside this, let's finish, then you can make your comments, please.
Thank you. My comment here is the gap, one of the infrastructure gap in the state as far as PSC is concerned is the absence of the laboratory, and that should be clearly marked in that particular bullet. So we don't just look at it and say, because the laboratories are really not captured in the PSCs.
Let me also say that you cannot, this is just a working document. It cannot give you all the details. Once they say there's infrastructural gap, it covers all the domains of infrastructure. So the idea is that we'll expand on this. Please don't think this is a complete document. It just gives you an idea. So infrastructural gap is wide, and you cannot neglect the laboratory. You can't neglect it. So please, let's not, you may not get some specific information, but if there are broad areas we feel we have not covered, again, suggestions have been made that this will going to be categorized according to health system building blocks, so it makes it more specific. So even at the end of this, if there are other elements of the health system building blocks that we feel has not been given attention, let's make those comments. But I want us to be structured. So please make comments related to this. Don't make other comments, please.
My name is Oniko Riba Osobera, Health Records Officer. What I want to comment is on the time frame about the plan. I think we should also involve the hospital administrators who have known how to plan time and equip everything about hospital planning. And if we want to capitalize on what is said now, the time frame should be under the long-term plan or the short term. If we are saying it should be 6 months from now or 1 year, we should specify. And I'm saying it should be within 1 year frame. Thank you.
Continue, please. Or do you want me to take over? From you.
All right, thank you very much. So based on Prof's guidance, we'll just focus on the slides that we have in front of us and the resolutions that are there. Now, we also, based on conversations over the last 2 days, talked about the need to strengthen our human resources for health. And one of the issues that we captured was accreditation for our medical university to support their trainings.
That will be expanded to say accreditation for existing tertiary training institutions, because even School of Nursing, all those, they require accreditation. So we expand it. That solves that problem. The next one, please.
So for the next one, we talked about community validation of all the plans that we develop across board to make sure that there's community ownership of those plans, and we're not just the ones discussing the plans here without the community.
So that's part of a post-summit activity which will be done. So let's go to the next one, please.
In that same line, also the strengthening of the ward development committees and having them doing their routine meetings, which is also a part of that same community engagement process. Now, we also talked about all our strategies for health service delivery needing to include integration and resource efficiencies.
And in addition to that, we said we'll define the minimum service packages, not only for primary, but for secondary and tertiary, the Bayelsa model. So that's the adjustment there.
Next slide.
Okay, somebody wants to make a comment? Give me the mic.
Please, this #1 bullet, closing the gap of primary healthcare, and we talk into infrastructural gap. I think we agreed here the major problem that we have is human resources.
We'll have a separate bullet point for human resources.
Okay.
There will be a separate bullet point that addresses the gap of human resources. Okay.
So now looking at our human resources, We agreed that we needed to conduct a needs assessment for our human resources, as well as a training needs assessment for human resources at all levels of the system. We also agreed that there is a very deliberate need for a plan for recruitment, for remuneration, and for retention. We did agree that there's a need.
Sorry, we need to expand that one because it's not just, that's the only bullet point that speaks to employment. So we expand it to healthcare workers, especially community healthcare workers. But we need to expand it because we need healthcare workers at all levels. So that should be expanded. I think that's the comment. We expand that one. That's the problem of at least gives a guideline for inadequate human resource. Yeah.
So we also talked about redistribution of PHC workers and an accountability mechanism for PHC workers. But again, in line with our conversations, we'd also need to expand that for the accountability mechanisms to include all health workers.
So in essence, as part of what we said is to have a performance management framework for our health workforce. And that includes accountability and the like. So there will be a distinct performance management for health workforce. Yes, yeah. Health workers. The redistribution is not just primary. Yes, so
across board for all of the areas, we'll be looking at expanding them to include all health workers, just to be able to again accommodate all of the conversations that we have here so far. Now, the issues around in-service training for people that are already working as health workers, to make sure that there's a deliberate plan to be able to implement some strategies around that. Now, again, we'll expand that to be all health workers, to also be able to accommodate all of those different in-service trainings. And hopefully that would also answer to some of the concerns and suggestions around making sure that there are opportunities for people to continue to get training and retraining even after they've qualified as practitioners.
Any comments on this? We'll go to the next slide.
There was something I said that is related to this, and maybe we can just insert it here. I did recommend that we need to incentivize the consultants in these existing tertiary hospitals to go to outreach centers and offer services and mentoring. We did it nationally and it yielded a very good result. We call it the VOS, Volunteer Obstetrician Scheme, where we partner with gynecologists, SOGON members of PAN, and they were going on visitation to distant locations, and we paid them stipends for their fuel and accommodation, and they return back to the city center after some days. That was really, really very good. And we can just smartly insert it here.
I think it's already there. If you look at the third bullet or fourth bullet point, incentivization for rural posting of highly skilled health workers. So it's there already. It's there. Yeah, it's there. No, it's there. It covers broad so that we don't focus on only consultants.
Chairman, sir. I want us to look at the second bulletin there. Review and strengthen the system of recruitment, remuneration, and retention of community health workers. In my opinion, this summit is all about health, and it cuts across the 3 tiers of healthcare delivery system: the primary, the secondary, and the tertiary. So much concentration has been given to the primary health care. If we are talking of recruitment.
Sorry, we have revised it. We have revised
okay.
it.
What I want to say is that second bulletin should please be corrected to include that review and strengthen the system for recruitment and remuneration and retention of health workers, doctors, nurses, midwives, and pharmacists, med lab, everybody working in the health sector, not community health workers alone.
It has been corrected. So do we have other comments on this? We'll go to the next slide. One house, please. One house, please. One house. One house, please. So let's continue, please. Next.
All right. She has touched one part of the comments I wanted to make. is that particular point which should involve, even if it's primary health care, it should be focused on community health. Just make it as providers of primary health care. That's how it should be captured if we're referring to primary health care. The second part is we have passed that slide because you didn't recognize me. That's why I couldn't make. On the issue of accreditation for the Bayelsa Medical University, we're talking about healthcare. In many cases, there may be misinterpretation with the way it is captured. Remove that for medical training. That point, the previous slide that has accreditation, remove that for medical training so that it doesn't appear like it is for one particular area, maybe medicine, whereas you will have nursing, pharmacy, and other areas. So please expunge that part. That's my submission. Thank you.
Okay, thank you very much. We'll do that too. The next one is
So we've asked, hello, colleagues. So we've asked for the team with the ICT to start trying to update this in real time to effect some of the corrections and changes. What is important to re-emphasize is that we've all had some agreement here that these pointers will be changed to reflect the context for all health workers across board. That's what we have agreed, right? logistics system. And then we also have something around expanding the minimum package of primary healthcare services to include oral health services. So these are what we've drawn from the different sessions. So are there any comments or feedback or suggested changes for this slide?
Dr. Biomo, because the FMC and AGUA is just a little addition to bullet number 1. Integrated logistics and supply chain management system. It's actually a management system. Thank you.
All right, thank you very much. Any other additional comments around this?
Just to add, maybe the issue of, let's say, the environmental health has to come here. You have to insert the bullet, one bullet when talking about environmental health and waste management.
All right, thank you very much, sir. So we'll include an additional bullet point around this logistics systems that speaks to waste management and environmental health management. Are there any other comments around the supply chain and logistics system? All right, so we'll move to the next slide. Now, on the next slide, we talked about designing and implementing quality management systems for all healthcare facilities across the different levels of care. We also talked about mechanisms for biannual state reaccreditation of health facilities and annual health facility assessments in the state. We spoke to a research fund that would help catalyze local research, and also a mechanism for presentation of research from the different health institutions to help support the development of annual operational plans. So now looking at this, are there any comments or feedback or suggested changes to this particular slide? All right. So these are the 5 slides that we have on the resolutions. So I think that so we'll have one comment. Just hold on.
Please, I'm sorry of taking us back. Odoko Joseph. On item 2.1.2, develop a mechanism for a biannual reaccreditation of health facilities in the state. In the tertiary institution, we'll talk about accreditation. Normally, we have reaccreditation after 2 or 4 years. So let's add that of the training institutions also for reaccreditation of the tertiary institutions. Thank you.
All right, thank you very much.
Let's conclude this session by just to give some context to what we are doing. What we did here was just to give an overview of some of the comments, opinions, suggestions, recommendations of panelists, speakers, participants. And so the intention is that having done this and received input from you, we're going to make it more concise and more strategic in terms of the various domains which we are going to share with you. But for emphasis, so that people don't get worried about what we are doing, I want them to put that slide that was presented this afternoon so that we let everybody know that your concerns will be addressed. And we are just collectively trying to say that this is what the general areas we discuss. Yeah, so if there are some areas we forgot, you can let us know so we can make it more concise and put it in the various building blocks. Can you share that, that slide, please? No, it's not there. Or you put it. Sorry. Okay. So again, this is to tell you, no, go to the other one. Go to the first one. So this to tell you that we will not neglect these issues that we have put here. And these are resolutions that we have actually made because we have even discussed it. And that one, that the state needs a health law, which the governor has already proclaimed within 3 months, and the health policy. Of course, that we need a state council of health meeting. and that we need an accountability framework, which is part of the performance management. Human resource for health, that we need to employ additional health manpower and strengthen the process of remuneration, distribution, retention, attrition. That will be covered by a resolution. That we also have to have a system of performance, Bayelsa system of health care worker performance management. That has been agreed. For service delivery, that we will need to look at core demand and utilization, geographical access, and specifically that we need to define minimum service package for our secondary and our tertiary healthcare facility. That's the resolution of this meeting. That, of course, that we need performance reviews beyond healthcare worker. We need performance reviews for our healthcare system, and we must have annual performance review. That's the resolution of this meeting. Of course, we have suboptimal care. That is performance review will sort out that problem and give us indication. Inadequate coverage. Then we need I think it's part of what we stated there, weak referral system and how to strengthen it. Quackery, then increasing regulation to avoid quackery is there. Then emergency services, we have dealt with it already. If you go to healthcare financing, we talked about, people have made recommendations that we'll look at our post-summit to see how we can increase funding to primary health care. So there are many summations, suggestions have been given that have been noted that can be part of the law when we discuss post-summit. Low insurance coverage, that was part of the resolution that we have just decided here. Health infrastructure, one resolution we have agreed here is that we need a state health infrastructural master plan. That's a resolution because we'll do a needs assessment and we need a master plan that covers laboratory and every other person. So we have taken that resolution. That's the resolution. Next slide, please. Partnership. We have talked about partnership with and PPP policy, that we need that in our state. The research, we talked about that the fact that we are going to develop a research policy for Bayelsa and priorities, and we need to have an agenda for research and look for funding for it. It is there already. That's the resolution. M&E, we have listed the electronic medical records, ICT infrastructure, medical products, that's where we talk about logistics and supply chain, which we have already talked about. We don't have a central medical store in Bayelsa. We are recommending there as part of the resolution, there's need for a central medical store in Bayelsa. Community engagement, that's part of what you also discussed. Health security, we have just discussed it through Center of Disease, Bayelsa State Center of Disease Control. Social determinants, perhaps we have to make a general statement on that because that did not reflect in our resolution. But we have to make a general statement, just to give you a perspective that we have considered everything you have said, and we are going to structure it this way and make it more concise. And we're going to send you the final version. But of course, somebody will read the communique now that gives an abridged version of what we have discussed, because the communique is going to be released to the press. But this is more technical, and we assure you that we will make it as technical as it's expected to be. Thank you very much. So Dr. Stowe, please read it so that we can go.
So thank you very much, everyone. And I'll hand back to Dr. Stu for the communique.
Thank you very much, Dr. Chideke, Honorable Commissioner for Health, Permanent Secretary, our Honorable Chair of the LOC. My assignment is very simple. We've drafted a communique that speaks to all of the conversations we're having from day one of this Health Summit. And so we thought it was wise that we share with you, but I don't think I'll be getting feedbacks because Chairman has already said it. I've captured most of the things, and we're going to go back to the drawing board and draft, go through it, and then maybe when we're ready, we'll send it back to you guys for further feedback. But this is just a media-friendly version of the resolution, so it captures virtually most of the things we've spoken to from day one. So I'm just going to read through. So it's the Bayelsa Health Summit 2021 communique. The Bayelsa Health Summit 2021 tagged Bayelsa Health, Better Health for All, held at the Chief Arod Dapa Brie Conference Center, Golden Tulip, Onopa Villa, Yanagua. Bayelsa State from Monday, the 19th to Wednesday, the 21st April, 2021. The overall goal of the summit is to achieve improved health system performance in Bayelsa State through strategic planning and stakeholders engagement. About 800 participants attended the summit, including representatives from the Federal Ministry of Health, State Ministry of Health and its parastatals, United Nations agencies, health development partners, and private sector players. Participants also included National Assembly and State House of Assembly members, representation of professional health associations, traditional rulers, civil society groups, religious leaders, and security agencies, among others. The summit was declared open by His Excellency the Governor of Bayelsa State, Senator Doye Diri. Other dignitaries included former President Dr. Goodluck Ebele Jonathan and the Honorable Minister of Health, Dr. Osiage Haniri, as well as the WHO country representative, the DG Nigeria Center for Disease Control, and chairperson commissioners for Health Forum, among others. Dr. Osan Enabulele, President Commonwealth Medical Association, delivered the keynote address titled Successfully Implementing Health Systems Reforms. There were also plenary and breakout sessions that included panel discussions, guest lectures, and abstract and memoranda presentations. Participants discussed and made recommendations on various aspects of health system strengthening in Bayelsa State, including health security, universal health coverage, primary health care, improving emergency medical service delivery, performance management, and quality improvement in health and healthcare financing, among others. At the end of the 3-day meeting, the participants made the following observations and resolutions. The observations made are: 1, the Bayelsa State government has made significant investments in the health sector, and it is creating an enabling environment for improved health and socio-economic development. Despite these investments, the Bayelsa State health system remains weak and characterized by poor health indices. The challenges facing the Bayelsa health system are cross-cutting and include gaps in health security and in almost all building blocks of the health system. Bayelsa State has critical deficiencies in health, human resource for health, healthcare funding, healthcare insurance coverage, and health infrastructure amid challenges of difficult geographical terrain for accessible healthcare and poor demand for health services. These challenges are surmountable and require urgent corrective interventions to guarantee improved health outcomes for the people of Bayelsa. So our resolutions: 1, His Excellency Senator Doye Diri, the Executive Governor, pledged the strong and renewed commitment of the government of Bayelsa State to completing all ongoing health projects in the state, strengthening primary health care, and transforming the Bayelsa health sector in line with its prosperity agenda. The government of Bayelsa State pledged to enact a Bayelsa health law to provide legislative backing for all proposed health system reforms. The state government pledged to establish a state center for disease control to coordinate the development and implementation of the state's health security agenda and ensure all living in Bayelsa are protected from public health threats. Number 4, the Bayelsa State government, through the Ministry of Health and in conjunction with other stakeholders, will develop a 10-year Bayelsa State health system
improvement plan to guarantee improved health outcomes for the people of Bayelsa. The state government pledged to implement the improvement plan and enabling legislation for sustainability. The state government pledged to revive and strengthen emergency medical services in the state and officially launch a new Bayelsa emergency medical service and ambulance system, BEMSAS. The state government, summit participants, and all partners in the health system pledged to expand the scope of partnership in Bayelsa health system. So this is our Bayelsa Health Summit 2021 communique. Thanks for listening to me.
Thank you very much. Please, a better round of applause for him. We're now moving to all right, we're going to be taking brief remarks. This is the closing ceremony proper now. So take brief remarks. I crave your indulgence that when you're called, just speak for 2 minutes maximum, please. 2 minutes maximum. So I would like to invite first from FHI 360, Dr. Hadiza Kamufu. Please put your hands together for Dr. Hadiza, just for 2 minutes, please. Okay, while we're waiting for her, I would like to invite the immunization advisor from the Nigeria Governors Forum, Dr. Avuwa Oteri. Please put your hands together for Dr. Oteri, please. 2 minutes.
Thank you very much. Honorable Commissioner, I will make this remark standing on existing protocol. Well, we are glad that this summit has taken place. It's the first step towards having a strong health plan for the state. So this is something that we said is very good. And we just pray that most of the resolutions will be implemented. And we are going to share this with other governors so that the health of all Nigerians can be taken seriously. So this is a step that Bayelsa has started that we'll share with other states to also see how best to do it. So on behalf of the Governors Forum, I think we commend the states and we pray that these resolutions are well taken and addressed. Thank you so much.
For FHI 360, I'm told Dr. Kolawole will speak on your behalf. Chief of Party, please put your hands together for him as it comes.
Why are you not clapping for me? All right, I'm Dr. Kolawole Olatubosun, Chief of Party, Sharp Task Order 2 project. Bayelsa is one of the states we work, and incidentally, this is one of my, in fact, this is my first time in Bayelsa. I was speaking with the Honorable Commissioner earlier, and even if this was a talk shop, this is a fantastically put together talk shop. And it is not a talk shop. The resolutions and the decisions that have been taken here are far-reaching, and I've already reached out to some of the other states that if you are not in Bayelsa, you are missing, that you have a lot to learn from Bayelsa, and I'm going to be one of the ambassadors of Bayelsa in my journeys across the country and the world. Thank you very much for a fantastic event.
Thank you. Make sure you eat bole and fish before you go. snail too. I think one of the panelists said they gave us snail in shell. All right. I would like to invite to also speak Gavi consultant, Dr. B. Dieng. Please put your hands together for Dr. B. Dieng as it comes for 2 minutes also, Daddy.
Thank you very much, the Honorable Commissioner. Please let me stand on the existing protocol. I will be speaking on behalf of the Gavi's Senior Country Manager, Dr. Hamid Reza. Some of you might not know, we have signed an MOU with Bayelsa State. Between Gavi and Bayelsa, we will be the first partner coming on board in Bayelsa starting this year. After providing all this solar equipment which is already installed in your wards, we would like to improve further, talking about the immunization agenda and the health system strengthening in Bayelsa State. I look forward to meeting you in the coming days, but it's not my first visit. It's my second visit after 2009, but it has been a lot in terms of improvement in Bayelsa. What I have discovered is impressive. That's why I was contributing to all these questions. Sorry for disturbing you if there is any. And it's something which is really overwhelming. In my past experience for the 42 years in public health, I can tell you that you are on track. God bless you.
Thank you, Mia Kamer. I would like to now invite to also speak for 2 minutes from the National Primary Healthcare Development Agency, Southeast Zone, Dr. Eric Mwaze. Please put your hands together for him.
So, yeah, the Honorable Commissioners, the Chairman, distinguished colleagues, development partner representatives, ladies and gentlemen. I speak on behalf of the National Primary Healthcare Development Agency, and specifically the Chief Executive Officer, Dr. Cesar Schweib. So I do really want to congratulate Bayelsa State for this very, very auspicious summit. Actually, it's coming at the right time. If anybody says that this is a talk show, let the person go and examine his or her head. And I mean it. The beginning point for all development agenda in any society is to talk. You must discuss, agree and disagree. So this for me has been an excellent outing by Bayelsa State. And I feel I should continue to remain in Yenagoa, quite frankly. And since I came, the kind of smiles I have been seeing on the faces of Bayelsans, quite frankly, I can only tell you to continue. You have been a wonderful host. The way the welfare package, the entertainment, the organization of this very summit, I can tell you is top notch. And I want to say as an agency, MPHCDA, we happen to be your lead partner for PHC. And I will personally ensure that I continue to persuade my ED to work with the state, not only to finalize the strategic development plan, but in some other opportunities that I have identified as very good areas of collaboration, so that in the next set of surveys, I will be very happy to see that Bayelsa has turned around to report better indicators. But for this one, permit me to thank you and to say a loud congratulations. And please Let us keep and maintain focus and continue what we are doing. We are definitely, I join Bubakar to tell you that you are definitely on the right track. There's no question about it. So congratulations, and thank you.
Thank you very much, sir. Indeed, we have no choice but to smile. You know, when your guy is smiling, don't smile now. Come and see. We have the smiling commissioner, so we're all copying. much. Thank you very much, Dr. Abe. Noasa. And you know, when he said the commissioner is always smiling, I think that his smile is a weapon. You know, when someone is always smiling and he's your boss, the day he frowns, won't you run? So because he's always smiling, when he gives you instruction, you want to do it so that he will not frown. That is a weapon. So I would like to invite now to speak for all the speakers, Dr. Elesami, please put your hands together for him as he steps forward. It's a pleasure to have you. Okoido-san.
Thank you very much. Let me say I'm really glad and excited to be here. Many years ago, I've been here, but just for coming for accreditation and go back, especially when I was working with Shell in Port Harcourt. But ever since I arrived, and before I arrived, I'd seen that the Honorable Commissioner, Professor Goin, and all the other members of the team, that you really mean business. And let me assure you that you've put in a lot of effort. It's not easy at all. But the good thing is that you are still very young, so you have the energy. And I'm sure you translate all these things into action. I also want to assure you that from our own side, at the Federal Ministry of Health, the Standard Committee, we cooperate with you fully, very, very fully. Just don't relent on your effort. Have the handshake across your colleagues in other states, and you get a lot of ideas from them. And you avoid the mistakes that so many people have made. I believe honestly that by the grace of God, this will be followed by action, 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 and it will be translated into reality. God bless you. Thank you for inviting me.
Thank you very much, sir. Indeed, cooperation and partnership is all Bayelsa needs right now. I'll now invite the smiling commissioner to make the closing remarks. Please put your hands together for Dr. Pabara Newton-Igwele.
Permit me at this point to unmask myself, taking the vaccine, even though I'm not fully immune. There is quite a lot running through my mind. It is now the business is beginning. We just started. And the task ahead of us is quite difficult, but I know it's surmountable. And because of that, there's something that gives me strength. And I would just want to draw that strength by making reverence to the anthem. Oh God of creation, direct our noble path, guide our leaders right, help our youth the truth to know, in love and honesty to grow and live in just and true. Great love, the height attain to build a nation where peace and justice shall reign. You may be seated. This is my driving force to build a nation where peace and justice and equity shall reign. I want to thank everyone. When I mentioned this first to my peers and most of my staff, that this is what we need as a state to move forward. I'm not here to make money. I'm here to serve our people. I lived just across the government house here when I was a small boy. I've seen government come and government go. I've seen leaders come, leaders go. I see leaders amass wealth here in the States. And after several years, those wealth disappear. And the lasting legacy is to build the people, to build a healthy nation. And that is what I stand for, and that is what I'll continue to do. And at this juncture, I want to thank everyone who has made it to this summit. Be rest assured that I'll keep no sleep in my eyes or have no rest until we achieve every one of these goals and targets we have set for ourselves. And at this juncture, I want to apologize to everyone. Sorry, I'm becoming very emotional because I know where we're coming from. In the line of my duty, I must have shouted at most of my staffs and subordinates to ensure we get the right thing done. I am very sorry for everyone that I have shouted at. It is not in my making to step on your toes, but it's because I want the Bayelsa people and Nigerians to be healthy, to be strong, to have a good life and a better life. Not just a statement, but to everything in every space of our development, I want Bayelsans to have a better life. And that is why I must have done that. And so once again, I want to thank His Excellency for buying into this vision. It's not every governor that wants to spend in things that people do not appreciate. Your Excellency, Senator Doediri, wherever you are, thank you very much for supporting Bayelsans. And I know you have said oftentimes that you will not play politics with the development of our people. And thank you everybody, and God bless all of you. I love all of you. God bless you.
Thank you, thank you. Forget it, forget it. It's not every leader that will come out and apologize. Commissioner, you have emotional quotient. That's EQ. You know, some people have IQ and zero emotional quotient. But Commissioner, not cry on me, I'll be waterworks.
No. See, at this point, Commissioner need to cry. That apology is for me. No be small shouting shout for me. AJ, the mic is not working. AJ, this upstairs, Commissioner, I forgive you. I forgive you. I forgive you.
You see, one by one, they are coming. You are forgiven, sir. But you know, say this your style ain't good. By doing public apology, you don't have to go and start telling everybody one by one, I'm sorry. Now, I know they vexed now. And you just kill 20 birds with one stone. How many people did the ministry where you offend? All right, thank you very much. I'd like to invite our chairman of the local organizing committee. Believe me, Prof has done an awesome work, but Prof, I'm not going to agree work under you. Because when you look at Prof, you know he's a workaholic. To work with her, you know go sleep. The next thing you'll be dreaming, you'll see Prof face.
Caribbean, see, before you call Prof, there's something I want to say. You say you know go work with Prof. I hope so you mean that, because me, when Prof called me, say come and defend what you are saying. Prof never even asked me question, my leg don't shake. Now one man wey need to take rubbish, he wants the best. Please, once again, put your hands together for Prof, please.
You take the vote of thanks.
Thank you very much. The Honorable Commissioner for Health, distinguished participants, let me stand on already established protocol. And I need to thank the Almighty God for this privilege, for His mercy. We have been on this for more than 5 months or so. And this is the last day of this summit. This is the first ever Bayelsa Health Summit. And by the grace of God, this summit has been informative, has been very engaging and rewarding. And to my mind, and as has been attested to by many people, it's a huge success on account of all of us. So let me use this opportunity to first thank the Honorable Commissioner for Health. I know when he came in as the Commissioner of Health in the last government, he also told me this, that he believes that there's need to have a discussion, a type of health summit. And when he came in this second government, he had that vision, that dream has become a reality. I thank you, Honorable Commissioner, because it takes a lot of courage to do what you have done now. It's not easy. It's not easy to take that commitment to do this, because Organization of Health Summit, we know the stress you went to going to Abuja, even looking for funds. And we know the stress you will go through even after the summit. So we commend you for the courage, because it takes a lot of courage to do this. And it's only somebody that has that leadership mindset that will take the courage to do something that is different. You have appreciated His Excellency, the Governor, and we also need to appreciate on behalf of the Planning Committee, His Excellency, for buying into the vision of the Commissioner, because if he did not support you, it would have been possible for us to organize this health summit. I would like to, at this point, also particularly appreciate all our special guests at the opening ceremony and during this summit. Of mention is the former president of Nigeria, President Goodluck Ebele Jonathan, who was in attendance and gave us encouraging words. I'd also like to appreciate the Honorable Minister of Health and his team. They sent a team from Federal Minister of Health, and they were with us for 3 days discussing about this health summit. Regards go to them. We also need to appreciate all our partners, UN agencies, international partners, private agencies that supported us in one way or the other. A number of people gave us financial support. A number of people gave us technical support. We appreciate you for your kind gestures. We want to appreciate our speakers, our panelists, the people that presented memoranda, the people that presented oral abstracts. Without your contribution, this summit will have been meaningless. You brought value to the table. Your contributions made the whole summit successful. So on behalf of the Bayelsa Health Summit Planning Committee, I would like to thank you and I appreciate you. I would also like to, at this juncture, appreciate every participant. Without you, in fact, we're even worried at the planning committee that is it possible that after the first day, there will be nobody seated here. But look at the numbers. First day, 800. Second day, more than 400. Today, I'm sure we're up to 500 or even more. That shows that we have active participation and people are actually very interested in the health summit. So I want to appreciate everybody seated here and those at home and those that have left, those that participated online. Your presence, your participation made this summit a success. I also like to thank my planning committee. We have worked very hard. And I need to say this, we have worked very hard and we have all sacrificed without asking for any reward. And I said it without missing any word. No member of the planning committee has gotten any logistical allowance for this, for planning. The commissioner is here. We have sacrificed our time and our resources to ensure that this summit succeeds. And I want to appreciate every member of the planning committee. I know that you have worked time and day. Most of us have not slept very well. Most of us are just waiting for the end of today to go and sleep. I can mention names, but almost all of us have not slept very well because we have been working to see that this summit is a success. So I want to thank everybody. I also like to thank our MC and the colleague for everything you've done, and the media, and every other person that's put this together, from the ICT and every other person. We appreciate you for all the efforts. As Commissioner said, we have already achieved from this health summit that we are here even discussing, that the governor came and made some pledges we have achieved. But the partners have also spoken to that. On account of this, we will continually see transformative changes in the Bayelsa health sector. to the benefit of all of us and to the benefit of the people of Bayelsa. Once again, I want to say thank you. And at this juncture, I want to wish every participant, everybody, journey messages back to your various destinations. Thank you and God bless you.
Thank you very much, Prof. And Prof, I've changed my mind. I will work with you. You know, in most events, when they do vote of thanks, they don't ever call MCs. Prof, for calling MCs, I will work with you.
Prof,
Even
me,
if I see you for dreams, I'll take it like that.
Prof, me, I'm already working with you. Just that I'm scared. I'm working with you.
So we've come to the end of the maiden Bayelsa Health Summit. Shall we please rise to our feet as we take these victory shouts? Bayelsa Health Summit 2021. Hip, hip, hip. Hip, hip, hip. Hip, hip, hip. Clap your hands together for yourselves. Thank you very much for taking 3 days out of your busy schedules to be here in Bayelsa State. We wish you safe journey and we hope that you come again. Come again. My name is Taribio Wilson Owefawari. In case it is a mouthful, just say TWO. I will still answer. Thank you. 2. Just say 2. I will answer.